Good afternoon, everyone. Welcome to day 3 of SALHN Research Week. So we had a really exciting morning where we had some great posters and students visit. And now we're through to our keynote session today, Achieving Equity Strategies for Inclusive Care. So we've got a range of excellent speakers. And in the theme of achieving equity, I'm repping a program that SALHN's working on, the Flash GM program, which is glucose monitoring in Aboriginal health out at Noarlunga. And I'm also, I'm the Manager of Research Governance and Ethics here at SALHN, and I'm also co-chair of the Aboriginal Health Innovation and Research Council, and I've got another member of that council here with me today, Mark Thompson, who will also co-chair this session with me, so I'll pass it on to Mark now.
Thanks, Owen. My name's Mark Thompson. I'm the Director of Aboriginal Clinical Services and Strategy with Drug and Alcohol Services South Australia. And this meeting. But to start with, I'd like to acknowledge that the land that we're meeting on today is the traditional lands of the Kaurna people, and that I'd also like to respect the elders past and present and emerging. And I hope everyone has a great day today with some great presentations. So the first presentation is creating safe spaces. What does LGBTQ inclusive design look like in mental health services, followed by a Q&A. And I'd just like to introduce Professor Damien Riggs of the Education, Psychology and Social Work at Flinders University. And Damien is a professor in where I just mentioned, but he's also the author of over 200 publications on gender, family and wellbeing. So that's quite an achievement in managing to do that many publications, I think. That's fantastic. And with Damien is Dan Thorpe, who is a research assistant at Flinders University, working with Professor Riggs and Susan Nunn, and presenting on behalf of Susan Nunn, Advanced Clinical Psychology at SALHN. So yeah, welcome.
Hi everyone, I'd also like to begin by acknowledging that we're on the unceded lands of the Kaurna people and acknowledge their sovereignty as First Nations people. Is this working? Do I need it?
Yeah.
Is it done now? It's not got any lights on it. Do you want to use a mic pack? Yes, sadly, Susan is sick, so she can't be here today, so you get to hear from just me, but I want to acknowledge that a lot of the work that I'm going to be talking about today was led by Dan, so it's a collaborative team effort, and obviously we've got Suzanne here as well today, who's part of our team. What moves us forward? Yep. So this is the border project team that we're a part of. There's a large crew of us from across Australia, many of us here from South Australia, but we all worked here yesterday, and we're all actively involved in this project. Obviously it's in collaboration with SALHN. So why is safety an issue specifically for LGBTQ people? Well, we know that safety looks like a lot of different things, and the research for decades has continued to find this, that LGBTQ people go along to services and they get dismissed. So people say, we don't serve you, so we get explicit hostility. We also get people saying, look, you know, I'm not opposed to you, but I don't know anything about LGBTQ people, so I don't know how to work with you. So then LGBTQ people are involved in what Christian Newman, another member of our project team, has called inclusivity labour, which is we have to do the work to tell people this is what it means to support us, this is what it means to include us. And then broadly, which I'm not going to really talk about today, but something I'm passionate about and our project is passionate about, is about the design of the space. Does the space give signals, give messages that it is safe for LGBTQ people? So when all of these things don't happen, people would disengage, and we know there's quite robust Australian data on LGBTQ people's disengagement from mental health services because of distrust, so they may need the services, but they fear going, they've had negative experiences in the past, so they simply don't go and they struggle and cope or don't cope on their own. So our project, which is funded by the Medical Research Future Fund, is to look at identifying what inclusive multidisciplinary mental health services can look like, and that's what I'm really talking about today. And then our next stages are to co-develop with SALHN, with users of lived experience, a model of care that's inclusive and can be implemented within SALHN mental health services, and then to evaluate that model of care. So that's what we're doing across 4 years, and we're just into the second year now. So we're very good timing that we actually have some findings to talk about today, rather than just giving you a broad overview. So for the project, one of our main things that we're using is the IPARIS framework, which is an implementation science framework that helps us understand the barriers and facilitators of change within any implementation framework. So there's 5 domains that the IPARIS framework covers.
And that is innovation. So is the thing you're trying to do, the implementation you're trying to do, are people open to change? The organisational context, which is SALHN more broadly, and then the Department of Health even more broadly. What is its views? How does it elaborate its willingness to engage in change? And then the outer context, so everyone else, politicians, lawmakers, policymakers, politicians, people who could have a relationship to SALHN mental health services. So the first thing we've done, and we've been doing that since we got ethics approval in May, is a rapid context assessment. So what we do is we go through, some of our project team go through with staff at each of the sites, and we fill out the IPARS, which looks at, people's readiness and barriers to change. And we're going to talk through a bit about this now. This is scored in a way that I think is slightly odd, but anyway, that -2 is a barrier and +2 is a facilitator. And we also took endless, copious notes around what did people ask us about filling this out? What did they tell us? And people even thinking about, the data from the Flinders ED ward, it's people really wanted to talk about this topic. So there's a lot that we have had going on already that's sort of informing what we're going to do next. Oh God, now I have to do this by myself. So what we found, so this is a wonderful visual map that I don't know if it's big enough for you to see, but it's a wonderful visual map that Dan put together that sort of maps out how people responded to the 5 domains. So we've got 5 domains and then multiple questions under each of those domains that sum up to give us an idea of what the barriers and facilitators are. So we found, often small differences between those domains. So innovation, recipients, local context, institutional context, outer context. But we found strong relationships between some of the barriers and facilitators across domains. So what that tells us is that what we pitch this project to the MRFF in the first place is that change can't be one thing. It has to be holistic. That's the word we keep using, and people keep saying, what do you mean by that? It has to be systemic. It has to look across all of the different areas rather than saying, well, we'll just put up posters, or we'll just have people wear badges, or we'll just train some staff members to be better at doing this. What these findings suggest is that it needs to be across all of the areas. There's no one area that stood out as being right, SALHN's already got this, that's done and dusted, we don't need to look at that. All of the areas had barriers and facilitators. And the areas that we're finding in the papers we've literally just written in the last week is that it comes down to 2 sort of areas. One is around leadership. So we need leadership to be engaged in representation. This needs to come from leadership. It needs to people, SALHN staff in particular, want to be told, this is where we're going, this is where we're heading and why. We need buy-in then from leadership to do that, and that's resourcing, both financial and in kind. And then leadership needs to engage in external engagement to bring in other resources that maybe SALHN doesn't need to replicate. And then for frontline staff and for us as the implementation team, what really people wanted is, we're open to this idea, but we need you to tell us exactly what it is, which makes sense. People are busy. People don't have time to do vague things. They need clear directions about what to do. We need conversations. So we've found barriers, and I'm going to talk about those in a second. People need opportunities to talk about their fears, their worries, the things that might be a challenge for them in terms of implementation. And we also need to recognise that there are already LGBTQ champions within SALHN, within mental health services, that we need to draw on. We don't want to leave those people behind and say we're doing something better than what you've been doing already. We're just building on that. So in terms of the ethnographic findings, so that was the IPARIS findings. This is the ethnographic stuff that sat alongside that. So we did a thematic analysis of that. One of the key themes was around people's emotional responses to the idea that we were going to be implementing change. So some people were very resistant to that. So we can see a quote here. Someone said, the gender fluid patient not allowed to use the female toilets, even on days they are female presenting, because as a mother of teenage girls, you know what I mean. Well, I don't know what they mean. I can guess what they mean, and it's probably not particularly nice about trans people, but that's that sort of explicit resistance to inclusion. So that's where we're going to have those conversations. We're going to have to talk to people about what is it that makes a barrier for you. Then some people spoke about having embarrassment and shame around things that were already happening that weren't up to scratch. So someone said the wrong gender markers get printed, for example, on a medication label, which in turn leads to misgendering. So someone gets called the wrong name or the wrong pronouns are used, and I feel physically embarrassed. So this idea of a very visceral response to things not going as well as they could be at present. But that doesn't mean that these people don't want to change. It's just we have to work through that feeling of shame. But also another effective response, a positive one, was lots of people spoke about wanting to change. So someone said, overall, the feeling was that the staff are keen for evidence and open to shifting practice. And that's what we want to hear. And then people also, the other key theme was people speaking about facilitators of pathways towards positive change. So this is where we can really capitalise on this desire for positive change. So, and these are positive, but they're not great in the sense of they're sort of status quo things that sort of rely on the goodwill of individuals. And we want to, in the implementation, move beyond that to see system change. So one sub-theme was around leveraging existing resources. So some people said things like staff are working hard to fill gaps in the system. I know I'm magical thinking that there wouldn't be gaps in any system. There will always be gaps in the system, but the idea that people are having to plug gaps rather than gaps being proactively identified and addressed is what this suggests. The importance of safety signals, and this was big, and this was great, and this is something we can sort of already say this is being well done. There is a culture of staff having pronoun badges and putting pronouns in their email signatures. There was lots of talk about posters. We saw lots of posters. We took photos of lots of posters. So this is being done well. And then a call for knowing what to do. So this sort of builds on some of the stuff from the previous theme of people saying, look, we're open, we want to be inclusive, but we don't know how to do that. So someone said we need education on a staff level that moves beyond token definition. So people felt like they'd been given some training, they'd been given some information, but they didn't feel like that helped them work in that holistic way. So to again reiterate, I know there were some barriers that I talked about, but we want to acknowledge there are good things already happening. There's LGBTQ champions. We saw examples of people wearing rainbow scrubs. We saw lots of flyers. We saw people with pronoun badges on. We saw lots of amazing things happening within SALHN mental health services. But not everyone knows about those. So we talked to staff who said, oh, I've never heard of that. And we're like, well, it's happening just in this service over here, and sometimes in your own service, but people didn't know. So part of it's about getting the word out. And then it's also about consolidation. So there was examples of different people doing the same things rather than working together to do the same thing, which might require less resources. Some gaps we identify can't just be addressed by new procedures. We do need new procedures and policies, and that's a whole other conversation about our audit of the policy library, that there's gaps in that, lots of gaps in that, so that's definitely work that will need to be done. But we also need to talk to staff about how they feel about those changes. And it's a big part of our evaluation is how do service users and staff who aren't LGBTQ feel about the implementation, because we want buy-in. We don't want to just go, this is what's happening, do what you're told. We want buy-in from everyone. But, there overall was this general sense of a commitment to change. There wasn't even though we put some barriers up there, I would say that was a minority of people. The majority of people really wanted change, but acknowledging that the wheels of institutional change can be slow, which is true for any institution. So what's next? Currently, we are interviewing staff and we are interviewing service users. Dan has got flyers, Suzanne's now got some as well. Please, if you would like some to put up in your service, come and see us and come and see Dan, who's sitting here with a big beard and glasses. We'll happily give you some beautifully printed on nice quality paper ones that you can put up. That's going through till the end of the year, and we're going to start concurrently analysing those data so that early next year we can start doing our co-design, which is talking to the LGBTQ subcommittee, talking to other people with lived experience about what can an implementation model for SALHN mental health services reasonably look like. Then we have a year, which is probably very naive of us, but that's funding, to try and implement those changes that are agreed upon by everyone. And then we have another year to do evaluation. So in a way, replicate what we've done this year, which is it working? What are the barriers that are still presenting? What are the new traps and pitfalls that have come up that we can then identify? Because what we're looking to in the biggest scheme is to then have material documentation that can be handed over to other local health networks so that they can go, right, we don't have to do this whole thing. We can just implement these things that have a robust evidence base rather than them having to start from scratch like we have with SALHN. That is everything. Hopefully I've kept to time, yes. So any questions? Much appreciated. Hello.
Hello. I'm going to wait for the microphone.
Sure.
Oh, John.
Thanks, Damien. Hi, I'm Tiffany from College of Nursing and Health Sciences. Really interesting work, and I noticed you talked about facilitators, but you didn't talk about facilitation, which is actually a really key part of IPARIS. And I'm wondering, do you see that coming in this next stage, in the co-design, and do you plan to do an assessment of that?
Yeah, so we're actually, it's slightly confusing, and I probably confused you, that we use the IPARIS, which is different to the IPARIS. So it's about doing what we've done, which is identifying those things rather than looking at the facilitation aspect. Is that correct, Jan?
Yes.
Yeah. So that will be part of our co-design is, yes, doing that work, because we're sort of, obviously 6 months of co-design is still less than anyone would like, but we need to do all of those things in those conversations. Once we see what people are saying, then we can work on that aspect of facilitation. Does that make sense? Yeah. Someone else had their hand up? Go for it, Susan.
We'd expect the facilitation would come out of the co-design process. So that will be looking at the implementation. And so whether that's like local champions with someone will also have be employed within the service to support that broadly.
And we will also have, looking at someone, hopefully we have money to buy out a SALHN staff member for a fraction of time to do on the ground implementation for that year alongside us as team members. Yeah. Yes.
You spoke about. Yeah. There's someone right there. Right there.
Hi, I just wanted to ask if you had plans to roll this out to all of SALHN or just the mental health services in SALHN?
So it's one of those things with funding that the MRFF call was around mental health. So we had to frame it around mental health. And also, the person I knew was Susan, who's in mental health. So yes, but the intention is that we develop materials, documentation that anyone across any local health network, including outside of South Australia, can use the things that are shown as best practice to be the best thing to do. So it's definitely not meant to end here. We've definitely got a whole lot of plans towards the end evaluation that are producing materials with people with lived experience, videos, to give people an insight to why these things are really important to do.
Can I follow that up? Just because I wondered whether you had any inferences about the rest of SALHN, understanding that you've looked at mental health, but it exists within a whole organisation. You mentioned the emergency department and so forth. So I think from a whole organisation perspective, it'd be interesting for us to know whether mental health was representative or whether it, because it might actually be doing this a lot better than the rest of the organisation is doing it.
So it's kind of like, even though the funding was around mental health, it's hard to contain anything. So we did do it in the ED. We did do it in other places that aren't solely mental health. And obviously the policy library audit is not just restricted to mental health. So we certainly would never claim that we've looked at all of SALHN, but we're definitely not limited by just to focus on mental health. It's sort of, we need that to remain our primary focus, but it's certainly our data, and even when we've written up these papers, they're not all about mental health. So it definitely speaks to the network more broadly. Yeah.
You spoke about the importance of leadership commitment. Damien, you spoke about the importance of leadership commitment and buy-in. I'm just curious, has there been any engagement, focus groups or surveys with SALHN mental health leadership to, I guess, test what that currently looks like, the attitudes towards the change from leadership? I don't think I've seen any.
Yes, in the sense of that, and that's why I wish Susan was here to talk about that. She is that person, and Suzanne as well, who have a lot of conversations with leadership from before we even applied, you know, getting the application done through till now. And then obviously part of the co-design will be amping that up in terms of those conversations around what we think is possible and what leadership thinks is viable. Will be an important part of it. And I think, I really wish Susan were here, because I'm not a SALHN staff member. So I'm this external person who comes in and does this work. But have you got anything you would want to add to that, Suzanne?
No, I don't know who's been
Yeah, I think Susan would be the best person to ask that, because she knows who's engaged in the process so far from exec. But I think definitely at the moment, like, we're pushing for interviews. So I think now it's not too late. It's like a key time now to have like exec staff.
Yeah, right.
To influence the change.
That's good to hear. And that's when Susan's back on board next week. That's something that I'll talk to her about, is that, maybe we need to do we were just like, staff, talk to us. We need to do some actually really targeted conversations with leadership. Thank you, that's a great point.
One of the thoughts that I had around the culturally and linguistically diverse groups and Aboriginal health dimensions as well. And so is there any strategies for how that can be kind of part of the implementation?
Yeah, so I forgot to mention, we actually did an initial desktop examination of all SALHN, not just mental health services, online materials, and we looked at whether those are intersectional in their nature of looking at LGBTQ people alongside people of faith, alongside people in rural areas, alongside First Nations, alongside CULT. What we found was really good representation, relatively speaking, for First Nations people. So quite reasonable stuff for rural, remote, and spirituality. We found zero coverage of LGBTQ stuff. So part of our intention is for this to be an intersectional project. It's just about how the conversations we're currently having with staff and service users around who comes and speaks to us, and how we are trying to do, because we don't have ethics approval to do direct recruitment, so we can't go and tap specific people on the shoulders, but it's definitely a focus of what we do, even if we have some sort of backup plans that if this doesn't work through this approach to recruitment, we might go back to SALHN ethics and say, can we do some direct recruitment? Can we do some yarning circles? Can we do some conversations with CULT people by direct recruitment? So we're sort of seeing what happens naturally and then seeing what we might need to supplement that with.
Excellent, thank you so much. So the next speaker we have is Amy Hawke, but this one's actually a video recording from idea to impact, lessons in implementing a sensory room in acute mental health setting. Amy is a principal occupational therapist within SALHN Mental Health Services. She has played a key role in driving the implementation of the sensory room at Margaret Tobin Centre, combining clinical expertise with a passion for translating research into meaningful practice. Amy is dedicated to fostering a culture of learning, collaboration, and continuous improvement, ensuring that mental health care remains innovative, person-centred, and responsive to community needs. So we'll move across to that now.
really supports in that reduction of restraint seclusion through early intervention to de-escalate and to reduce agitation and distress. It's a least restrictive practice. What we know is that patients within psychiatric inpatient units, and particularly PICU environments, are often experiencing increased arousal, agitation, external stimuli, and that these cohort can really benefit from grounding and calming sensory strategies, which has really been the primary focus of our sensory room. You can see the image of our sensory room at Margaret Tobin Centre here. So at the time, this was the most high-tech sensory room in South Australia, with an integrated multi-sensory experience using top software and technology. So the sensations in this room could be individualised relating to patient preference. So let's move on to the research itself. So we were fortunate to be awarded a SALHN inquiry grant in 2023 round of funding to support our research project. This was extremely valuable for us to push the project forward. So our aim for the research was twofold. It was to determine if the sensory room did impact on rates of PRN medication use and seclusion rates. And we also wanted to understand consumers and clinicians' experiences of using the sensory room in a PICU setting, including facilitators and barriers to use. So we used a mixed methods realist approach to do this. Our quantitative review involved the analysis of medication charts and SLS incident data to look at trends, and our qualitative approach used interviews with clinicians. So we interviewed 12 clinicians and 8 consumers, and then we thematically analysed this information using the theoretical domains framework, or the TDF, and the COM-B, which are 2 frameworks that are used to map characteristics of behaviour change. Before we get to the results of our study, let's talk about behaviour change. So to understand how to implement change in healthcare, we first need to understand the drivers of that change. And that's where the COM-B model comes in. It's not to be confused with a COM-B band, although I hope that this image helps you remember accurately. So the COM-B model, capability, opportunity, motivation for behaviour, is a simple framework really for exploring behaviour change. It identifies the core conditions required for any behaviour to occur. Why it's valuable in implementation is because the COM-B proposes that for any behaviour change to occur, there needs to be 3 components. It's capability, it's opportunity, and it's motivation. This framework really helps us to identify what influences behaviour and then helps us to guide strategies for that change. So in terms of capability, we want to ask, do clinicians have the knowledge and skills to use the intervention? In terms of opportunity, we want to be asking ourselves, are there environmental resources, time, organisational supports in place? Is there a supportive culture? And in terms of motivation, we want to know, do they see this intervention as valuable? Do they believe it works? Do they feel confident that it aligns with their role and their identity? So by mapping the barriers and enablers against this COM-B model, we were able to start identifying the areas that were real barriers. And hint, it's not always training. And then we chose targeted intervention strategies. Taking this one step further, we looked at the theoretical domains framework and mapped the TDF and COM-B. So this really provided a further layer for us to analyse the behaviour change. So looking at the TDF, you can see that it's made up of 14 domains, and each domain lets us dig deeper into a specific psychological, social, or environmental influence on behaviour. So when we overlap the COM-B and the TDF, we can really see that this gives us a robust framework for behaviour change. You can see in this image here. The way I like to think about these when they're aligned and the COM-B and TDF come together is that the COM-B is that core engine which defines the essential conditions for behaviour, capability and opportunities, motivation. And the TDF sort of looks at is a bit more like a diagnostic toolkit, so it unpacks each of those COM-B components into the more granular domains. So putting these together really helps us then identify and target behaviour and assess current practice, and helps us to identify those barriers and enablers to implement change. So let's move on to the findings of our study itself. So as previously mentioned, we'd interviewed 12 staff and 8 consumers, and then we thematically analysed and mapped against the TDF and the COM-B frameworks together to see what were the barriers that facilitators for this implementation. So within the domain of capability, we discovered that nursing staff expressed that they felt they did not have the adequate knowledge and understanding of how to use sensory rooms. So this was a prominent barrier to implementation of the intervention. That lack of knowledge meant that nursing staff faced challenges in how to explain sensory mod to consumers and really limited their use of the room, impacting consumers' understanding of the potential benefits there. frontline workers that were supporting the implementation. It was really important that they had that knowledge. Technical skill to use the room equipment itself also came up as a common theme. So, this staff quote here saying, "I learned it by trial and error." So really an understanding of how to actually set up the room in terms of the iPad, switching on the computer, those type of things was a barrier. Most consumers have never experienced using a sensory room, however, were open to try something new, and they really expressed their desire to learn more. From a behavioural regulation perspective, following use of the sensory room, consumers' positive experience reported, or their reported positive experience, facilitated further utilisation of the room or the intervention. So several consumer participants reported that their experience exceeded their expectations. So, there's this one quote here, "It brought out a lot of emotions, calmed me a lot." In the domain of opportunity, we found that social influence had a significant impact on uptake. So consumers reported that they were positively influenced by their peers' experiences and recommendations to use the sensory room, as well as staff recommendation. So when consumers then shared those positive experiences with each other on the ward, on the unit, it encouraged others to request to go and use the intervention or the sensory room. This participant quote here, "I loved the first time staff invited me and the second time I asked." We also found that environmental context and staffing resources was probably the most significant barrier to implementation. So specifically the location of the room and the staffing requirements that were thus needed. So all staff reported that the location of the sensory room was a major barrier to access and minimisation. The location of the room made it difficult for staff to take patients to the room and to follow the required safety protocols. Also, noise from the surrounding environment was reported to disrupt the sensory experience of users. This could have reduced the effectiveness of the intervention as well. SHU staff members were required to facilitate patients' access to the sensory room, and this was a real barrier to implementation, given that the staffing numbers meant that then it took their two staff members off the ward itself. So both staff and consumers in the interviews expressed their frustration with this barrier. So positively, consumers reported experiencing the room as a safe space within the busy PICU environment. Within the motivation domain, it was clear in our analysis that professional roles significantly impacted on the uptake, and that's particularly notable in the interviews that came out with the nursing team. So naturally, the sensory room was a new practice, and many of the nurses did not believe that this was part of their role as a nurse. And some reported that they viewed that the sensory room was really within the role of the occupational therapist to facilitate. Beliefs around consequences were also found to be a significant facilitator and barrier. So naturally, positive staff attitudes around the sensory room as an intervention really impacted on the uptake or the use of the intervention within the daily ward routines. So staff attitudes around whether they believed that the intervention or the sensory room was effective really impacted on whether they would take a consumer to use the room. And there were those that did believe that it was an effective intervention were often quite eager to take consumers within their shift. It was found also that positive experiences really impacted on the beliefs about consequences. So again, that does link back to another domain around the social influence, but social influence also impacted belief about consequences and so on. From our analysis of the qualitative data, there's several key interventions or recommendations that we would and will make moving forward. So these recommendations were developed in line with the findings of the study, and as you can see, many of these recommendations span across multiple domains within the COMB framework. So they go across capability, opportunity, and motivation. Some of those key recommendations, I won't go into all of them, but some of the key recommendations around education and training really is around the staff facilitating regular education sessions on sensory approaches for our room use. Co-design pamphlet for consumers on admission to the unit regarding sensory approaches and room access and availability. Establishing interdisciplinary leads to support the model really would support and encourage staff use, particularly thinking about the beliefs around role identity and the beliefs about consequences of or impact of the room. Having interdisciplinary leads would really support and encourage the use of that. explore opportunities for consumers to share experiences of the sensory room, whether that's in ward or community meetings or with others, during a mealtime, for example. This also does lead into sort of that using of social influence, so encouraging staff to share experiences of supporting consumers to use the sensory room with other staff. Using a feedback board for consumers to comment on experiences of sensory approaches would really support around identifying the benefits of the room with others and sharing that and using that social influence to garner interest. Seeking consumer feedback and using these stories and getting permission for these stories to be shared could be a powerful testimony. Similarly, embedding a feedback loop to staff around the use and the impact of the intervention. Encouraging staff to use the sensory room themselves to get that personal experience, I think, is going to be a really key one, to see, firsthand, how does this room feel, how does it impact on my own senses, would be really important. From an environmental perspective, and this was, as I said earlier, one of our major barriers, we would really need to ensure that the sensory room is in an accessible location with minimal noise disruptions. And in our new PQ build that's due to open later this year, that has been factored in, and our room is in a much, much better location. And really looking at modelling, so again, establishing an interdisciplinary lead group to model, support and encourage staff use is going to be extremely powerful. And exploring opportunities for consumers to share those experiences as well will be powerful. In the future, we would use the combi analysis prior to implementing any QI, actually, not just a sensory room. So any QI, new intervention or change process to assist potential barriers of implementation and strategies to support the intervention. We've recently published our findings, and this is a real-world study that provides various learnings for use in clinical practice. So please take the opportunity to have a read of the article, and we can distribute the link to that later. And now back to that plane analogy. So landing the upgraded plane or implementation isn't just about hoping that people will automatically do things differently. And I think it's about really deliberately shaping the conditions that make change possible. So using the COM-B and the TDF models overlapped, we've been able to think about capability, opportunity and motivations, really systematically reflect on these factors. So we're now able to explore and anticipate where change might stall, identify what supports are needed, and make sure the adjustments are practical and sustainable. And that's how we land our change plane safely, not by chance, but by design. I wanted to finish by acknowledging that there's been a large team involved in this project, and many thanks to each of them for their individual contributions. I wanted to really thank Flinders Foundation and the SALHN Inquiry Grant Round for financially supporting the evaluation of this project and for this research to be complete. Thank you for your time again, and I apologise I wasn't able to be with you there in person today. So Dr. Suzanne Dawson, who was a co-investigator in this study, and Gary Pettinger, who is the Advanced Nurse Unit Manager at Margaret Tobin Centre, will now be available in person to answer any questions you might have around this project. Thank you.
Fantastic. So, yeah. Do we have any questions at all for the team? Do we have any questions at all for Susan? So, yeah, Gary, Susan, do you want to come up to the front? Do you want to give them that one?
Thank you.
Yeah, I just noted that given that it takes 2 nursing staff off the floor, that staffing was one of the biggest barriers to accessibility of the room. Is that something that's going to be looked at going forward, particularly with the new PICU in relation to the staffing to enable ongoing use?
Should we both talk to that? Yeah, absolutely. It was a massive barrier straight away as soon as you saw the room. So it was real world, like Amy said, and it was with the best intentions, but it was very awkwardly placed. So you had to walk through a corridor, 2 doors. So it was always kind of going to be challenging. And actually the results weren't talked about, but there were no changes in seclusion or restraint, and that was probably a big issue, as well as change in practice taking a long time. And I think you said, or Ngoni, our nurse, said that nurses will still use PRM medication for a while, even alongside, but that would change with time. But in the new build,
for
For those who don't know, we're building a brand new psychiatric intensive care unit, and the sensory room, much better place, like front and centre. And also the current one we've got is, what we had was, as you said, 2 nurses past a locked door into an airlock, then into a sensory room. Do you want to take an agitated patient into that space? And no, absolutely not. So you need 2 nurses, and that was just challenging. And plus, the new one, it can be unsupervised. You'll have a glass pane on there, right by the nurses' station, walk by, yep, going okay, next person.
And sorry, one follow-up question. Do you know of any of these sensory rooms being used in any busy emergency departments?
Yeah, we would love to get sensory spaces in EDs. No, it's not been written about yet. They are using sensory modulation and sensory approaches in EDs in other areas in Australia and New Zealand. And yeah, hopefully at some point that we can explore it here.
Okay, maybe SALHN can be first.
I'll just add to that as well. Real estate in ED is prime, hard to get.
Any other questions? Yeah, Michael.
Is one enough? The question is one enough?
That's a really good question, because the new PICU is going to have 2 pods, 6 patients, only 1 sensory room. 2 would have been great. Again, space was a problem. So they made the second one into an interview room. But yeah.
And then in our new rehab build, we've got, again, 2 pods, and there's going to be a sensory room in both. And I know Carlin, for instance, have also got sensory spaces as well as a sensory room. So we're starting to get more landscape in the new builds.
Thanks, everyone. So for the next session, which is Towards Employment as a Health Intervention, a co-design project for people with borderline personality disorder, I'd like to welcome Dr. Susan Dawson, Senior Research Fellow, has over 25 years experience working as an occupational therapist in mental health services in the UK and Australia. Susan is a practice-based researcher and is passionate about implementation and evaluation of psychosocial evidence-based practices in mental health care settings. This includes a focus on co-designed interdisciplinary research that aims to foster positive changes in approaches, practices and culture in healthcare services. Susan's research is informed by the exploration of service users and clinicians' experiences of care and aims to improve consumer care outcomes and experiences. Susan also holds a joint position with Flinders University, Southern Adelaide Local Health Network Mental Health Services, and also within the SALHN Mental Health Services. Jessica Giles is a lived experience project officer. Jess has lived experience of mental health distress as a young carer and has 20 years of experience across public mental health services, community services and the employment industry. She brings deep insight from her own journey and has worked in a workforce development. And Jess is also passionate about embedding structures. She's currently working across multiple initiatives that support peer workforce capability, co-design, and supervision models that honour diverse experiences. Thank you.
Thank you. And thank you for having us to talk in this session today. So Jess and I are going to be talking about a project that has finished, and we met with our research team over 3 years. So we're presenting the final results. And what we were looking at was a project that was co-designed, and it was looking at improving employment supports for people living with borderline personality disorder, or BPD. We acknowledge that we're meeting on the unceded lands of the Kaurna people today and pay respect to their elders. So this is our team. So it includes clinical lived experience staff from 3 different LHNs and researchers across 3 universities. And as mentioned, we did meet regularly, monthly, sometimes more often, sometimes less often, for 3 years. So there was a high level of commitment to have that group stay engaged. So in terms of like the broader context for this study or for this research is the assumption that employment is an important health intervention for people living with a mental illness. So if we think about the multiple benefits that we get from working, these are financial, social, and we know they're health benefits as well. And it's actually spoken about as a key determinant of health now. We also know that people living with a psychosocial disability associated with mental illness are seriously underrepresented in the workforce. So currently in Australia, 26% of people living with a psychosocial disability are in employment, and that's compared to 64% of people without a disability in employment. So individual placement support, I think, and many of us who are working in this space, should be viewed as an essential health intervention that mental health services across the LHNs should be offering to people. So a bit about IPS. So IPS is an evidence-based employment program that supports people with a mental illness to find and maintain employment, and it's regular paid employment. So this has been demonstrated as the best program for about 30 years. I think there's 28 RCTs have been conducted and 27 showed improved outcomes. So we're talking about 50 to 75% of people who will find and stay in work going through this program, compared to 25% if you're going through normal kind of service supports, which is the same as if you're just looking for work yourself. So there are 8 core principles, and they're in the bubbles at the top, that need to be strictly followed to actually achieve those high outcomes. And in public mental health services, it involves a formal partnership between Disability Employment Service, which is about to change to Inclusive Australia in November of this year. And the employment specialist is co-located with the community mental health team 3 to 4 times a week and works solely with consumers from that team. So previous studies have shown that if we make slight adaptations to IPS, we can improve employment outcomes for different consumer groups. So for people with complex mental illness, such as schizophrenia, they will quite often have functional cognition challenges. If we augment the program with cognitive remediation, we get better outcomes. So what we're assuming is that if we make slight adaptations for people living with BPD, that we might also get better outcomes, because not much is known for working with people with BPD. Oops, we're going all over. No, you're absolutely fine.
Trying to be helpful.
We got there. So what our project did is what we noticed. Are we on the right one? Yes. What we noticed is that individuals with a diagnosis of BPD were often quick to find work, but they were struggling to stay in jobs. So in terms of just a little bit about borderline personality disorder, it is a psychiatric diagnosis. And I guess it's characterised by the person experiencing what would be described as extreme sensitivity to perceived interpersonal slights, unstable sense of self, intense and volatile emotions, and impulsive behaviours that can lead to self-harm. The diagnosis of BPD is, there's a lot of stigma. So there's stigma, self-stigma, but there's actually a lot of stigma within services and a lot of stigma amongst a kind of general public as well. Although 1.7% of people actually are experiencing BPD in the population. So we thought it was an important issue to address. So our project outcomes, what we were looking at, I'm looking at 2 different things, so I'm getting confused here. So what we thought was, or what we assume, is that IPS is likely to be the best program for people living with BPD. And again, if we can look at specific strategies or approaches that could be helpful, we might get better outcomes still. And that people who have lived experience of BPD and people supporting individuals with BPD, which might include staff in the program as well as carers, would have the best ideas on what we could do to support the program, to improve the program. So our project aim, the overarching aim, was to co-design strategies to improve employment outcomes for people with lived experience of BPD and specifically participating in IPS. So what we broke that down into is reviewing current practice knowledge and looking at what the gaps were, as well as what the strengths were, understand the barriers and facilitators that were being experienced in the IPS program, and then co-design strategies to augment IPS. So there are various different co-design approaches. we selected Trishler's 7-step co-design process, and that guided our entire research process over the 3 years. So this approach facilitates the co-creation of services and programs or solutions with the people who are using the program, rather than us developing it for people. So for the remainder of the presentation, Jess and I will kind of talk through how we applied that 7-stage process over the 3 years. So the first stage we talk about as being resourcing. So this stage included conducting a scoping review, exploring employment interventions for people with BPD. So this was done, when did we publish it? 2023. So we finished we looked at studies up to 2022, and at that time there were only 7 studies, which is a very small number of studies that was specifically exploring employment supports for people with BPD. What we found is they all had combined work-related goals and psychotherapy, but there was nothing with a strong evidence base. IPS was being looked at in one large RCT that has still not been published, and that's with Origin, so that's with young people with BPD. I can say there are more studies, so when we looked at doing our papers this year, there's probably about 4 more studies, so that's encouraging.
Thank you. Hi, everyone. Is that okay? Yeah, cool. So this stage included focus groups with people with a lived experience of BPD, mental health clinicians and employment specialists to explore people's experiences of the IPS program. As illustrated by the quotes, we found that stigma impacts both support and employment outcomes for people. Behaviours were sometimes mislabelled as self-sabotaging. That was something that we heard quite a lot, indicating the need for reflective practice and supervision for employment specialists. Positive staff attitudes, things like confidence, availability, humanity and humour, built trust and supported recovery. And stigma really has an impact on people's self-esteem, impacting on their confidence, the belief about ability and motivation, therefore, to work as well. Fear of discrimination. Yeah, let me try and do this. Sorry, I just got to find the... Okay. Fear of discrimination was common experience for employees, many avoiding telling employers and concern around how they might be viewed or treated in the workplace. So education for employers was really quite vital to reduce stigma and improve outcomes. And supportive workplace relationships enabled safe requests for reasonable supports and adjustments, things like time off. Thank you. We also noticed that employment specialists really saw the value and impact of trusting relationships, being key to positive change, mutual learning and growth. Recognising that trust takes time really highlighted the value of the program's long-term support that it's able to offer. Staff emphasised the importance of building and maintaining trust for people with BPD and other mental health conditions as well. What also really became apparent was staff needs around education on BPD, being vital to understand its impact on people's functioning. And what was acknowledged is that warm referrals, so that personalised introductions by clinical staff really supported improving participant engagement in the program. Again, staff attributes, things like respect, calmness, patience, knowledge, flexibility and empathy were all seen as important facilitators. So the second step involves synthesising the information that was gathered in the resourcing stage and planning for the 2 co-design sessions. We decided to have 2 workshops, one specifically for people with lived experience and one for staff. And the third step being recruitment to the co-design workshops, and obviously for the focus groups as well. We really experienced some challenges in recruitment to both the focus group and co-design, but particularly in the focus groups. We particularly struggled with both the carer and consumer cohort. And we have acknowledged this as a limitation. We're not really sure that we have an answer. I guess we wondered if the focus was quite narrow in being diagnosis specific, or alternatively, were there a lack of people being referred who may identify as having BPD. Step 4 is around sensitisation, which involves providing information about the project and helping participants to shift their mindset into problem solving and designing improvements. These are on screen 2 examples of guided activities that we use to support this process. And so a lot of it was around providing information in a fun, kind of casual way, and helping people sort of work through free association type sentence building to help us move towards creative thinking. The purpose of the co-design workshops were to share those ideas, design improvements, and come up with strategies. The sessions are focused on coming up with solutions. We had already explored the barriers, and so we had facilitators at each table supporting the process. This slide shows the materials that we shared, or some of the materials that we shared with the groups, and what is pictured is actually a IPS participants' journey as collected through our focus groups. So barriers and enablers experienced at the different stages of the program, for example, job searching, job interview, etc. And then their comments and direct quotes about their experience in that particular step. Then in our co-design groups, we asked people what aspects of the existing program they liked, using the participants' journey. They could also consider what sort of strategies they would suggest for improvement. And the red stickers were for extra important ideas that people felt strongly about. To engage with the values and mindsets associated with co-design principles, it's important to support facilitator confidence as much as possible. And to do this, we tried to develop a facilitator guide which helped talk through each area of our planned activities, provided a reminder of the outcomes that we wanted to see as a result of those activities, and additional prompts for facilitators to use, which was really helpful in promoting creative thinking. Having a mixture of lived experience and research assistance as well as group facilitators further help to address the power dynamics and preference, the consumer voice.
Thank you. So what did we find? After the workshops, we synthesised the data and looked at strategies for improvement. So not surprisingly, most of the strategies related to the IPS core principles that I shared earlier. And these were originally developed through deep discussions with people with serious mental illness and the developers of the program. So it had already come from lived experience. So this slide shows some of the strategies that participants identified and prioritised, but they were already within the IPS program. But we've still talked about these in our publication because we still feel these are important for the, I guess, IPS leads to emphasise when they're working with people with BPD. So these are our co-designed adaptations for IPS, and what we did was we split it up into participant groups because they were all slightly different. So the co-designed improvements that came from people with lived experience, and that's specifically consumer participants, were that they wanted a collaborative referral. So they didn't want anything written about them without them being part of that. It kind of seems pretty obvious, but normally referrals are done by clinicians. They also wanted streamlining of initial appointments. So there's a huge dropout early on in the program because people just feel overwhelmed by the number of assessment appointments. So it was very explicitly said, can they be streamlined and done conjointly with clinicians and the IPS employer, IPS lead as well from the DES provider. The carers, they were talking about having a buddy system support on the job. And this is an interesting one because there already is the scope to have a support person come in with the person, but that in some ways could be potentially more stigmatising because you're getting, a spotlight on someone's coming in to help this person kind of engage. And if you think about it, when a lot of us are at work, we quite often have someone that we can, either a supervisor or someone else in the team that we can go to. So the same concept was have a buddy system from within the job area. And it has been written about very infrequently, interestingly. In aged care, they were looking at it in Scotland as a way to kind of retain and support retention of staff. Then what staff were saying was they wanted peer worker support, which interestingly didn't come from our lived experience participants, in terms of just instilling that hope and seeing people having gone through that process of perhaps having a period of increased distress and being out of work but now working. And also workplace assessment modification. We actually took that final one off because we didn't feel that that really aligned with the IPS principles, which are very much around putting someone in work and then putting the supports around. And it wasn't really specific. It wasn't required for any other participant groups, so we didn't think that was specific for our study group either. So the final stage, building for change, we sought feedback from the workshop participants via a Qualtrics survey, and also IPS leads in DES and SA Health. We have Lucas here, who's our SA Health lead. And really we were checking out, are these strategies what you were telling us you wanted, and are they feasible to actually implement? And now we've been sharing it with key findings with the IPS leads across SA Health sites and also through publications. So we need to thank the Allied Health Collaboration Funding. We did this on a bargain amount of $20,000 over 3 years. Also all of our participants who engaged really beautifully through the process, and our project team. And there are some key references.
Thank you very much, Suzanne and Jessica. Excellent insight there into employment as a health intervention. Do we have any questions at all from any audience? Yeah, I got a question around, I guess, you mentioned about the funding, limited funding for this type of intervention or your assessment. Where do you feel the sustainability around this is, and how can this be modelled and expanded to other local health networks?
Oh, that's a big question. So that's outside our funding for the research, but we do have a IPS industry scholarship which is about to start, which is doing an economic analysis and social return on investment, because we've just experienced now, I think I can say, can't we, publicly, one of the sites that I was involved in setting it up, and it was thriving in the West, had 3 employment specialists, 65 active consumer participants, and they had amazing outcomes. The DES provider, who have committed statewide, have overall one business in the recent kind of reconfiguration of service funding, but they lost it for that area, so that program's just gone. So we have it's a big problem. So we have to take it up to the next level in terms of showing its benefits and then kind of lobbying. You weren't expecting that answer. Yeah.
Can I add to that as well? I think I think if you understand what's helpful in terms of recovery for people with BPD, there's a pretty big focus on relationships with people and improving those interpersonal skills. So I think given that the recommendations were really about improving some of that communication and relationship stuff, I feel like that's a really valuable takeaway that we can, use in whatever format. So I guess the biggest thing that stuck out for me is that and maybe it's a whole other can of worms, but I guess we're no longer people in communities. We're quite solo people and quite alone. And so I think we have some societal stuff around needing to connect with community and improve relationships across the board, and that's in our workplaces as well.
Thank you both. Really inspirational work. I'm guessing, given we're in the business of health and care and relationships, do you see the healthcare industry as being in a better position to be able to provide that type of support to people than perhaps some other industries, or was there a particular area of employment that you found that was more receptive and better at doing this type of thing and providing that support?
Yeah, that's a good question. The jobs that people get through the program are like very individualised. So we weren't looking at any specific sector at all. And that was probably a gap in it. We didn't really look at that, like Jess said, that broader community and employer. So we were very much like looking at relational within the context of the program.
Any other questions? Fantastic. Look, thank you so much. And yeah, another round of applause for Damien, Dan, Susan and Jessica. And that concludes the session for us. Now we've got a bit of morning tea starting shortly. And then at 2:30 we have the rapid fire session, which should be really excellent, particularly because I'm speaking as well. So look forward to seeing you all then. Thank you so much. I've got a box. I walked downstairs.
Good afternoon, everybody. We're going to get started if you wouldn't mind taking a seat. Welcome to the rapid 5-minute oral paper presentations. My name's Angie Goodrich. I'm the Director of the Continuous Improvement Unit, and it's an honour and a privilege to be able to hear some of the amazing work that the SALHN staff have been doing to improve the quality care that we provide to our patients. And actually, it feels like a bit of a CIP reunion. I'm seeing all these people in the room that have undertaken some improvement projects. So I'm like a proud mama bear, and I'm going to be cheering you on from the sidelines. So it's my absolute pleasure and to welcome Dr. Paul Tate, who's a Senior Project Manager. Is Paul in the room? Great. Hello, Paul. From SA Virtual Care Service, and Paul is going to be talking about behind the scenes, RACH nurses' voices on virtual aged care in aged care homes. Now, Professor Bradbury will be joining me in just a moment, and it's unlike Professor Bradbury to go rogue. So we have changed the structure slightly. We will do questions straight after the presentation rather than in the 3-session block. So over to you, Paul.
Thank you so much for that kind introduction. I'm just going to ask for a show of hands for how many people in the room have felt professionally isolated, sort of lost when dealing with a patient at any point in their career. So it might be you've struggled to find the right person to contact and so forth. This presentation's for you. My name is Paul. My background's a pharmacist, and I've come along to the virtual care service really to sort of introduce some research rigor into some of the things that we're doing. I'm just going to... this is a quote from the Royal Commission into Aged Care Quality and Safety. Some of you might relate to this even if you're not working into aged care. But the thing that really sort of struck me with this quote is the feeling of staff being overwhelmed in aged care. Now, around the same time that the Royal Commission report got published, ironically, the South Australian Virtual Care Service was funded. While it was funded for a different purpose, certainly over time we've connected with the aged care community, the residential aged care community, and we were really curious, I guess, about sort of understanding. Obviously, our clinicians were working with aged care nurses on the calls, and we were successfully either reassuring them or providing strategies, either prescriptions and so forth. But we actually didn't understand what was happening before the call and what was happening after the call. So this project was really devised to sort of just understand the broader place of the aged care nurses, and to try and understand if there's some things that we need to learn and things that we can do better. Okay, so the aim of this process was really to understand the experiences of aged care nurses, particularly working in residential aged care, while engaging with the virtual care service to support the residents under their care. So I'll go briefly through the methods because I want to focus on the results. So we emailed nearly 300 residential aged care homes across South Australia, and we asked for volunteer nurses to come and talk with us via Teams. We recorded all of the conversations, and actually that way we had written transcripts that we could pull the data out of. So we used an analysis process by Saunders, which very quick overview. We sort of looked through the transcripts and wrote memos about sort of generally the links and the gaps that we were observing. We extracted codes. For those who don't work in research background, this is really like taking out sort of units of meaning. So it might be that they were talking about the timing of the call, or the time it took to answer the call and so forth. And then we developed themes. So this is our theming. It's a busy slide. I'm sorry about that. Given the 5-minute time frame, I'm not going to go and provide quotes for every one of these. But essentially, we came up with 5 themes, and there were 2 sub-themes within them. So the first theme was aged care nurses seeking a way to manage the clinical risk in their situation. So most of the participants in this process described how it was the lack of medical care on the ground and a deteriorating patient. It was that combination that led them to calling our service. They also described that sometimes in the call that there were some issues that rose, so that might to do with swallowing or to do with medicines, that they didn't actually have supports on hand to manage that as well. The second theme was aged care nurses appreciated clear guidance at every point of the interaction with the virtual care service. So some of the nurses actually said, we know, we'll call under these circumstances A, B, and C, but then some of the nurses said the paramedic came to the facility, thank you, and would encourage the to contact the virtual care service about something that they hadn't even considered contacting the service about. I'll just, for the because of the time, I'll move on to the next one. So aged care nurses want the virtual care staff to understand the challenges they face, and this was really around 2 aspects of care. So one issue was that they commented about the service, the virtual care service is not a 24-hour service, and so often they'll need to contact us outside of those hours, and they struggled with sort of that gap in service provision. The other thing that came up, which was really interesting, that sometimes our clinicians would provide prescriptions, which was fantastic, but they didn't have ways to get that to the pharmacy. So yeah, there were some issues in terms of having to, corral family members to do that. Aged care nurses also seek reliable technology for which they have received proper training. So that most of them said that they, having a technology light system, they were able to use their phones and iPads, was brilliant. It was actually made it easier. They didn't need specific equipment or a specific app. But they did comment every now and then about the reliability and the performance of the technology. And the final theme was, this was brought up by a few of the aged care nurses around the support of the families. So on the whole, families were very supportive of the aged care nurse contacting the virtual care service. But sometimes, and particularly with cold communities, so people of culturally and linguistically diverse communities, were actually really clear that they wanted their person, their loved one, to be seen face to face, in person, and so they would encourage going off to the hospital, even though something like a virtual care service could help them. The other aspect that came up here was that the family were participating in the call, so it didn't matter if the family member was there physically in the facility or living in Sydney, they could be dialed into the call, and that was incredibly valuable. I'm conscious that I'm running out of time here, so I guess these points are really just to summarise that we know that we can help avoid potentially preventable hospitalisations, and this work actually reassured us that that's the talk on the ground in aged care. They were really excited about the very professional and effective communication and handover of all level of detail and continuity of care. We needed to stress, though, that there's more work that we need to do in engaging with the residents' families. Thank you.
Well, do we have any questions? have one question. Having that increased support, did that result in less transfers to the emergency department by having that link with VCS?
That's a very good question. So the study, well, the work that we did was really just interviewing a handful of nurses. So we didn't look at the numbers.
Sure.
That's another study.
Okay.
That's another ethics application.
That's next steps. Wonderful.
Absolutely. So,
great.
Yeah.
Well done.
I think that would be really a useful next step.
Thanks. Thanks, Paul. Okay, my pleasure to invite Alison Francis, the Quality Manager Aboriginal Health, and Simon Windsor, Manager for the Research, Governance and Ethics Co-Chair, SALHN, to talk on the SALHN Aboriginal Health Innovation and Research Council. Oh, hello, Ali. And SALHN Aboriginal Health 2025 Research Activity Report. So thanks, team.
Thank you so much, Angie. Thank you, everyone, for joining us today. We have got the, let's go through. We're presenting some work that Alison and I worked on, the SALHN Aboriginal Health 2025 Research Activity Report. My name's Simon Windsor. I'm the Manager of Research, Governance and Ethics, also co-chair of the Aboriginal Health Innovation Research Committee, and I'm the research lead on the Innovate Reconciliation Action Plan. And one of the programs is the T-shirt I've got at the moment is the Flash GM program, looking at glucose monitoring in the Aboriginal Family Clinic. And we're also joined here with Teresa Francis has joined us, the Executive Director of Aboriginal Health, as well as Andrew Burston, the Executive Director of Research Strategy, who've been very sort of instrumental in getting the Innovation Research Council set up. So that's great.
Yeah. So I'll start off with an acknowledgement of country. So we acknowledge the Kaurna people are the traditional custodians of the Adelaide Plains and pay respects to elders past, present and future. We recognise and respect their cultural heritage, beliefs and relationship with the land, and we acknowledge that they are of continuing importance to the Kaurna people living today.
So the report that we're talking about today is a partnership between Research Hub and Aboriginal Health, and so the aims of what we sought to do was catalogue and evaluate Aboriginal health research activities conducted within SALHN up to 2025, assess alignment with community priorities and ethical research practices, identify opportunities to strengthen Aboriginal-led research and community partnerships. So that was some of the aims of the work that Ali's led.
And the methodology, so we undertook a systemic audit of research projects from 2020 to 2025 involving Aboriginal health themes. Part of that was conducting some semi-structured interviews with Aboriginal community representatives, researchers and health professionals. I also completed a thematic analysis of qualitative data and quantitative assessment of our research outputs, funding sources, and our community engagement levels. And in that, we found that there were 37 projects with Aboriginal health relevance. A number of those were led by Aboriginal investigators, and the depth and continuity of community engagement varied with all those studies too. Some of the areas of emphasis were around infrastructure and co-design, data sovereignty, and long-term impacts over short-term gains.
So with the evaluation, there has been meaningful progress in embedding Aboriginal perspectives within health research. However, there are several challenges that persist. And so ensuring continuity and establishing a clear pathway towards long-term sustainability, diversifying funding sources to support Aboriginal health research. So that's operating funding, grant funding, industry funding, enhancing the translation of research finding into practice and community-informed outcomes.
Now, some of the key themes that came out of the report were the cultural safety and decolonising healthcare, and we had 3 studies relating to that. There was 3 for community-led and participatory approaches, 3 for service access and integration, 2 for workforce development and capacity building, just 1 for digital and innovative health solutions, and data sovereignty, and then 2 for quality improvement and evaluation.
So what's the next steps and what's the future state? So the report affirms the establishment of the Aboriginal Health Innovation Research Committee, which had its first meeting in July 2025, alongside the increased investment in Aboriginal health research, targeted capacity building initiatives, and the implementation of formal mechanisms for staff and community to engage in feedback. So from a kind of the next steps, so it's a dedicated point of contact for Aboriginal health research within SALHN to make that engagement easier, a front door type approach, implementation of a Aboriginal Health Innovation Research Committee triage process to enhance access and manage new and ongoing research priorities, and ongoing communication and refinement of processes in collaboration with internal and external stakeholders. And if anyone has the innovation research strategy, which is 2 days old, page 22, we've got supporting closing the gap as a key action in the strategy, and the call to action. Some of those are taken directly from the terms of reference of the Aboriginal Health Innovation Research Committee as well. And to describe what some of that looks like, there's some life cycle management principles. So anyone that does research, clinical trials or anything, be very familiar with some of these steps. So oversight, sponsorship and investigator leadership, operations and sustainability, escalations and engagement, and corrective and preventative pathways. So just having a way to ensure there's continuity for the research programs in Aboriginal health with some of those management principles.
Thank you. Does anyone have any questions? We've broken ranks here. We're doing it after each talk. So it was easier for us, and that's what it's all about. Any questions? So what did you expect to find?
Rob, you need a mic.
Yeah.
I think historically there has been a kind of intervention type approach where different parties, whether they're academic partners, institutes, come into SALHN and work with individuals, and it can be very fragmented. And so that's what we thought we'd see, is some of that, the need for more structure and some of those kind of management principles. And yeah, that's what sort of Ali found through her work.
So was it about where you thought it'd be, or not enough, or too much, or not in the right direction?
I don't know. I was fairly new at the time that I started doing it, and I guess I wanted to see where we're at so we knew where we could take things, and yeah, there was a lot of discontinuity.
And what that plays out to in the real, operational world is that some of the stakeholders that we work with, there's frustrations around, the startup times, the cost of that, and like people not meeting their project milestones and different things like that. So I think that does show the need for that structure and to be able to, offer that continuity to our internal and external stakeholders.
So some of this research informing how we deal with our Aboriginal community patients?
Yes, some of it is, but we'd like to see, I guess, it move forward with more community engagement and engagement of Aboriginal staff, and make sure that we've got a lot more Aboriginal leadership in research.
So then my last question is, how do you make it more visible?
I think that would be where the Aboriginal Health Research Innovation Committee comes in, because that's giving a central point of contact.
And I think one of them is around funding as well. Is getting funding, structuring the funding, diversifying what systems are available, and how we can support different programs, as well as build capacity. I think that's a key thing as well.
All right. Thank you. So, Charlotte Wade, improving skin to skin time. So So this is mother to child, newborn child, in elective in caesarean section.
Hello, I'm Charlotte. I'm a consultant anaesthetist here at Flinders. Thanks for having me back. And the reason I say thanks for having me back is this might sound a little familiar. I was at Research Week 2 years ago in 2023, and since then it's been quite a journey. So a quick recap, what did I talk about in 2023? I talked about skin to skin and the importance of that after a very personal experience at the birth of my daughter. And I think everyone has heard me overshare over the last 2 years about my personal journey. But here today, I'm at the end. I say the end, it's never the end, but I'm at a point now where I'm reflecting back on what's happened over those 2 years. 2 years ago, I was a fellow doing obstetric anaesthesia, and I noticed that skin to skin at theatre caesarean section was not happening. And I embarked on this project to bring into place the practice of skin to skin at caesarean section. And as a result of that, to allow mother and baby to reap the benefits of a very well evidence-based intervention. We decided by the end of the continuing improvement project that 90% of babies born at caesarean section electively will receive skin to skin post-delivery. We did a root cause analysis following the SALHN steps approach, and we found multiple factors across the board of why skin to skin was not happening at caesarean section. We used fishbone diagrams, Pareto charting, process mapping, the works. We did this properly. And what we did was implement a procedure. I put posters up everywhere that I could. They got taken down, I put them back up again. We made patient information and we handed that out to as many people that would take it. And I went to every opportunity that I could to talk about it. So you're probably all sick of hearing about skin to skin because believe me, I've given this talk a lot and I'm gonna keep giving it. So watch this space. All right. After we did all of those things, I re-audited and re-evaluated where we were at. So it was another snapshot audit looking at another approximately 50 caesarean sections. And we had got our rates up to almost 90%. So we almost met our aim at 88% of eligible mothers and babies having skin to skin. So we were really pleased about that. And to be honest, I thought that was going to be the end of the project, but of course it never is. So thank you to our colleagues in neonates. Dr. Ophelia Matatina did this amazing work in the neonatal unit to assess the impact upon the actual admissions to the neonatal unit. And just by providing such a simple intervention such as skin to skin, we halved neonatal admissions post-elective caesarean section for babies born by elective caesarean section, which in real terms means that 47 mothers and 47 neonates remained together in the first 6 to 12 months after this project was put into action. That was a 4% reduction in overall neonatal admission rate, and there was an estimated cost saving in that first period of about $125,000. So to all those people that thought that skin to skin was just about lovey-doveyness, there is a real medical evidence-based reason why we should keep mums and babies together. It's not just about facts, figures, finances, admissions, because these are real people. And the day that you give birth to a child is a day that you remember forever. It's life-changing. And we received the most beautiful consumer feedback about the project. One lady said that she had the most amazing birthing experience, literally the best day of her life. She was placed on my chest for skin to skin, a mere minute old, and it was the most mind-blowing experience of my life. Please keep this going. It is amazing. Thank you for making my daughter's birth something I'll remember till my last breath. Another lady said the way you carefully handed my baby over to me, making sure that we had immediate skin-to-skin contact, was a moment that I will always cherish. So yes, I can come here with that data saying that we've saved money, that we have reduced neonatal admissions. But to me, 2 years of work, that's what it's all about, because these are patients and this is why we're here. And as I said at the beginning, the work is never done. I'm not actually at the end. We had some data through today that showed that our rates of neonatal admissions have started to creep back up again. So guess what? It's time for some continuous improvement. So as of tomorrow, I will be back on the education warhorse. I will be going out there. I will be rewarming theatres, because I suspect we're getting cold again because people forget. And I will be embarking on another cycle. And I hope to come back again and educate anyone who will listen about why skin to skin is so important. Thank you everybody for listening. Thank you to the CIP team, and thank you to the neonatal department. My goodness, this could not have happened without midwifery, without neonates, and without obstetrics. I'm an anaesthetist, and I had an idea, and I think I was once called a lone nut for embarking on this project. But my goodness, it couldn't have been done without a lot of help and support. So thank you to everyone.
Thank you. Thanks very much, Charlotte. Does anyone have any questions, comments, observations? Someone must have something. Alison? Hang on, we need you to have a microphone. We're going to need you to have a microphone.
Just a massive congratulations, Charlotte, and just, I guess, the compassion that's shown through the work that you've done and the knock-on effect that that has on patient care, both for the mother and the child, but obviously, you know, kind of in the emotion and the impact that that's had on you and the joy that that's brought work is just an incredible achievement, and well done.
Thank you.
A beautiful work, thank you. Still 12% to go. I suspect that's going to be the hardest 12%. What's the plan?
Yeah, so I think aiming for 100% is really difficult, because there are some women that become unwell at elective caesarean section. Some babies do become well. So there will always be some exclusions, and some women don't want it. So there are some women that for their own personal reasons, they don't want skin to skin. So 100% is tricky, but as close to 100% is definitely my aim. I think knowing that we're creeping up with the neonatal admissions, I think some of the data has shown that we are getting cold babies again, that we are getting hypoglycemic babies. And so we need to start back at the beginning with providing the antenatal education. We need to make sure we've got warm theatres so that people feel comfortable doing that. There's confidence for the neonatal registrars in theatre, and making sure that at the change of registrars, we're giving them appropriate support and education. When you look at the spike in the increase in rates, it's at the changeover of registrars as well. So that definitely coincides with an education and training of doing skin to skin. Back at the start of this project, we realised that the neonatal registrars were provided so much training in resuscitating babies, but they weren't actually provided training in observing babies on the chest at caesarean section. So I think the neonatal nurse practitioners have been amazing at instigating education for the new intake of registrars, and I think there will be a lot of bang for our buck there in reinstigating that and making sure that's happening. Multifaceted, but we'll get there.
Thanks. I just wanted to make a probably more of an observation about it's been a bit of a theme of the talks this afternoon about barriers and facilitators of implementing a change in practice. And one of those that I have observed inside theatres, I'm an anaesthetist, is the education and the importance of education. So at the start of the process that I observed Charlotte undertaking, one of the really significant barriers was, you know, people like the nursing staff complaining about theatre being too hot and not liking it being too hot in there and going and turning the temperature down. And then, you know, as the process went on, they kind of got used to it. But it was really, I felt, only when we started to, or Charlotte started to present the numbers to say, actually, you know, all this effort and discomfort people were going through was actually making a difference for mothers and babies. And people's ears would prick up, and then they'd start to go, oh, right, okay, so there is a point to this. And then I felt like there were a lot less barriers and a lot more people encouraging, enthusiastic and willing to help out. And I suspect what you're seeing now is just either new staff or a bit of complacency in the process, but well done.
Thanks, Fiona. Yeah, there's a fact that I used with the nursing staff that I think that was really effective, was to say that the guideline recommendations for theatre temperature is ideally 23 degrees, but we were doing caesarean sections at 18 degrees in an orthopaedic theatre for emergency. So it was really difficult to say, let's heat theatres to 23 degrees when they were used to operating at 16 to 18 degrees. So we compromised at 21. And when I provided the education, I said the reason that we aim for 23 degrees is because even at that temperature, if you had an adult lying naked, it would be the same at 0 degrees as it is for a baby at 23 degrees. So would you ever go and lie out at 0 degrees naked? You'd think I was mad, I was bonkers. That is freezing. But that is what we're doing to a baby, even by birthing them into a theatre at 23 degrees. That's the same heat loss that would occur. And I think then you only start to realise how vulnerable these babies are. And I think bringing it back to those real terms really helped the nursing staff in theatres.
I think that's a really great point, though, in terms of the sustainability of the intervention. If you provide the so what is the impact of this, and then the staff understand it, more likely to be sustained going future. So that's a really good point. Thanks, Charlotte.
I think just before Charlotte disappears, but this project illustrates a lot of things about improvement and the learning health environment. So you can't do an improvement project and then forget about it. We've done it, it'll just keep going. So to sustain needs vigilance and repetitive measurement and observation and all the other things that go with it. So that's, you know, that's an effort that needs to happen. The other thing is that valid clinical data. You know, we're awash with data in the organisation, but how much of it actually helps our day-to-day clinical work? So there was some really important clinical data in that. One was the admissions to the intensive or the neonatal intensive care unit. Then there was what percentage are we maintaining our standard, 88% in a re-audit. But what if we had an environment where that was provided to us in real time at any time spot? So from developing standards, we develop our clinical quality indicators. There is so much discussion around the organisation at the moment. What are the appropriate quality indicators? Well, they vary. They vary from activity to activity, unit to unit, endeavour to endeavour. But we need to go find them, define them, and then find a way to continuously measure them. And then that would make the routine running of the organisation so much more straightforward to have valid clinical data fed back in real time. That's where we need to go. Thank you.
Thank you, Rob. Okay, it's a great pleasure to invite Dr. Ali Robinson, Director of Staff Wellbeing Consultant Emergency Physician and for SALHN, and Rhianna McLean, Senior Project Officer, Staff Wellbeing. And they're going to talk about embedding Schwartz rounds, fostering reflection, compassion and connection to transform culture at SALHN. Thanks, team.
Thanks very much, everybody, and good afternoon. It's really exciting to share the progress and improvements in the Schwartz programme over the last 12 months. But I'm actually going to hand you over to our wonderful Project Officer, Rhianna, to walk you through this year's data, and we'll be happy to take any questions following that.
Thank you, Ali. Okay, so Schwartz rounds. They're a safe space for staff to share, connect, strengthen compassion and resilience. In 2024, we held 11 rounds here at Flinders, and as of this year, we have run 18 rounds. Our evaluations demonstrates the impact of Schwartz rounds amongst staff. Our goal is to have equitable access across SALHN. Cue cards. So, Evidence shows that originally from first beginning our Schwartz rounds, we had around about 130 staff attend around at Flinders. Now we are averaging from a range of 180 up to 200 staff per round. We have gone from a pilot program here at Flinders to now holding regular rounds at Noarlunga and team-based rounds. And of those rounds, 70% of staff members are returning participants. We have quarterly planning meetings. We have a wider divisional representation across SALHN. And we now have a deeper understanding of craft groups and unit expectations, such as running rounds for theatres and anaesthetics for a breakfast. We are actively seeking grant opportunities to better understand the economic workforce impact. From previous scepticism, we now have a deeper understanding of the benefits these Schwartz rounds have on our staff. We have hosted local and interstate guests from across LHNs who have come to learn from us and our model of delivery. And within our Australasian community, consistent levels of participation and feedback consolidates our position as a centre of excellence. We're constantly improving in response to the feedback that we gain from our staff, and we are sharing that with our American and our Australasian counterparts. Last year, we had 1,891 staff attend a Schwartz round. Our biggest cohort is that of our nursing and midwifery, which is relevant to our workforce, with a close attendance with allied health and medical practitioners. We've seen growing numbers from rehabilitation, mental health, and women's and children's. We hope that all disciplines and craft groups get to attend a Schwartz round in the future. So looking ahead, our strategic program expansion, we are dedicated to having regular Schwartz rounds for medical interns and junior doctors. We have a pilot launch within allied health that starts in October, and our expansion to the repat for 2026. So Schwartz rounds are effective in connecting our SALHN community across hospitals and across divisions. So far, we have held 22 Flinders Schwartz rounds, 4 Noarlunga, and 4 team-based, including junior doctors and interns. Staff agree that Schwartz rounds accurately reflect the SALHN values of trust, inclusion, and empathy. As we look to the future, we aim to successfully secure grant funding to conduct robust economic and workforce analysis of the benefits of rounds. That's it. Thanks.
Thanks, team. Having come to a few Schwartz rounds myself, it's absolutely amazing. Do we have any questions? No? Okay, great. Thank you very much.
Thanks, Angie.
Okay, I'm going to invite Dr. Amy Kerr, Senior Consultant Neonatologist here at SALHN and SA Ambulance Service Chief Medical Advisor. And Amy is going to talk about implementation of a quality improvement program in SA Ambulance using evidence-based practice for improving quality. Is it the EPIC approach? EPIQ approach. All right, thanks, Amy.
Thanks very much, Angie, and thanks very much for having me here today and to fly the SA Ambulance flag. It's wonderful that at least we have one representative here, and hopefully over the years as we grow our research program and QI, we will have a few more. First, I'd like to start by acknowledging that today I'm on Kaurna land and that I acknowledge the traditional owners of country throughout the Adelaide Plains and South Australia and recognise the continuing connection to land, spirituality, history and culture. This artwork's done by a Narrandjeri man, Jason Lovegrove, and it was commissioned to show SAS's reconciliation journey, which is still very much in its early stages, but we do have one. So what I'm talking briefly about today is basically we use quality improvement methodology to implement a quality improvement program organisationally wide at SA Ambulance. It is actually in many ways quite similar to the very excellent SALHN CIP program, which I have completed, as well as a number of my colleagues. It has, again, sort of a stepwise approach, relying on your local data, evidence, working together, using all your lovely QI tools, and then implementing things effectively. And then in things that we're not so good in healthcare, actually evaluating what you do. And very much based on the plan, do, study, act cycles. So what did we do? Well, we started out, we understood why do we need a QI program? So we can get NSHQS accreditation. That was our main goal, but also really to promote improved culture and a structured way of solving problems at SAS. What I've learned in ambulance land, paramedics, short attention spans, love to solve problems and do it really quickly, but like lots of healthcare professionals, we don't spend a lot of time actually trying to understand what the problem is, let alone evaluating whether what we did helped or not. So we undertook some planning and ran a number of different PDSA cycles. And what we did was reasonably successful. So we've completed all of our 4 cycles. Well, 4 is still a little bit of a work in progress. But for number 1, it's something fairly basic. We developed some specific tools for SAS. So we adapted the EpiQ tools. You know you're successful when you've made the intranet. We ended up on the intranet, we've got our own tile, we were excited, got all our tools, so that was a good first step. So we ticked that one off. We ran QI workshops, so since I started at SAS back in August 2023, we've run 14 workshops, 6-hour workshops. We have about 20 to 24 people attending each one. I was really excited at the beginning because the attendance was great, and then I realised I worked for a paramilitary organisation and people were being told to come. As we've developed, people actually now want to come, which is great. But initially I was like, this is amazing. And then I'm like, you're all told to be here, aren't you? And they're like, yep. And I'm like, oh, okay. Whoops. But good news, over time, we've got over 100 people trained. I've had a number of my executive director colleagues come along and a lot of senior staff as well, but also people from across our organisation. So not only paramedics, but our nurses, ambulance officers, call takers, dispatchers. And we also have, very importantly, 10 staff that are now trained facilitators as well. Then moving into our quality improvement project facilitation, you can't just embed a QI program and expect it to run itself. You do need leads, you do need coaches, champions, subject matter experts. So I was able to get some funding for a paramedic colleague of mine, Michelle Thompson, to work as a quality improvement development officer, and she's been integral to our program. So in just under 2 years, we've now got 15 active projects going, which has been wonderful. And we've got and it's being embedded in the way that we actually approach clinical projects and clinical problems in the organisation, which has been wonderful. We've also had really positive feedback about the workshops, but again, it's lovely people come and have a nice time, but you actually want to see improvement in outcomes, so that's where we're seeing that with our projects. And then our final stage is trying to embed this into business as usual. So that's trying to convince my colleagues that hold the money that we need to keep funding. We need to actually try and overcome some of the barriers around continuing a program in our organisation. And generally speaking, it did help us become the only ambulance service in Australia that has an SQHS accreditation at this point, and we got it met with no recommendations. So my CEO was really happy, and he's like, Amy, you might have actually been useful. I was like, yes! So we'll see what happens because our funding's coming up towards the end, but fingers crossed we'll still keep it going. So thanks again very much for having me. If anyone's got any questions you don't want to ask me right now, that's my email. I'd love to hear from you all, and thanks again for the opportunity to speak.
So, Amy, my obvious question is, what's the difference between the way you've done it and the way we do it?
So ours is a little bit shorter. So
I meant in content.
Oh, in content, it's quite similar, but it's the same principle. So it's not a different program, just I've done a couple of different programs. So the reason why I like this one is you can deliver it in 6 hours and you can actually reach a large number of people. So I've had a lot of my senior colleagues do it. Whilst they don't necessarily go and do a project, they've actually had that exposure. So they don't need to go and do a 6 to 12 month course to understand it. They can do it in sort of 6 hours. That's probably the biggest strength. But to be honest, I think there's lots of high quality programs around and they're all quite transferable.
Yeah, so it's often said that just supplying the tools and the methodology without doing the cultural piece will fail. So how have you done the cultural piece?
So what we're trying to do is build it into BIU, like business as usual, BAU, all the three-letter acronyms, that's all I know now. So we have things like a 4-decision paper that's used across the organisation for pretty much anything you ever want to either get, change or do. So we're actually going to embed our QI methodology in that, and we've actually done a workshop to work with people to understand how can we actually embed quality improvement into your everyday practice. Got feedback that people want shorter things, and also the ability, and I'm sure no one here has ever worked in healthcare and you're told you have to implement something. So there's no point in understanding why you're implementing it because you have to do it. So how can we also design some processes around helping people implement things effectively, evaluate them? So sort of making it relevant to people. Give the people what they want, and hopefully we'll see it.
I think it also helps to have a compliant workforce. That's
They'll come to the workshop, but it's whether or not they do the projects, Rob.
Does anyone have any questions or comments? Sorry.
Amy, how are you going to measure impact or value on investment?
So I had the pleasure of one of my colleagues asking me to sit down with him and explain why there was any point to this and take him through a benefits realisation framework. So I have another 20-slide deck that I can take you through the benefits. But really it comes down, I think, to the projects and the actual outcomes that we have from that. Because as Rob said, you do the workshop, people like it, doesn't actually change anything. You want it embedded, you want the clinical projects and improvement in outcomes.
So we'd be interested in seeing some of
I can come back in a year if you like.
Oh, shorter time frame than
Shorter!
that. All right, thank you. Thank you very much. Marty, Bolter? So I haven't put my glasses on, but a prospective multi-site cohort study on the prevalence of frailty in patients aged over 70 years presenting after serious injury and implications for outcomes. Seeing as I've just reached 70, I'm very interested in this.
Okay, so Rob, then maybe this talk is for you to make sure we look well after you in the future. So, so frailty really is core business for the future in healthcare. There is an absolute boom in older patients, but we know that they have disproportionately worse outcomes, and that's not just because they're older, it's because of one of the main components of that is frailty. So hence this study that we did, it was a prospective study at 3 major trauma centres here in Australia, looking at the prevalence of frailty. But it was patients 70 years and older with serious injury. Now, we included patients who had an injury severity score of more than 12 or admitted under a trauma service or bed card or trauma surgeon or admitted in intensive care. So on we used validated tools to assess for frailty, comorbidities, activities of daily living and instruments of activity of daily living. And then we looked at the adverse outcomes these patients had during their admission, then at 3, 6 and 12 months post-discharge, and also who of them had a geriatrician review. Now the older people, quite a range of the fit, and the frail older person. Frailty, really complex, multifaceted entity, but the reduction in physiological reserve is a really major component. And essentially, how do they bounce back? So a fit older person after medical event, trauma or surgery, they bounce back to their baseline. A frail older person don't bounce back to their baseline, and with multiple sequelae to that, including worse outcomes and increased hospital length of stay. Just a quick note on major trauma too. Major trauma is the severity or the significance of injuries people sustain and not the mechanism of injury. And in fact, in older patients, the main cause by far worldwide is low energy mechanisms of injury or low level falls, and particularly in the frail older person. And that was reflected in this study too. So what did this study show? The frail group was about 14.7%, and the near frail group or the vulnerable group, 12.9%. It's probably higher, and I'll get to that in the next slide. What were the outcomes? About 25% of the patients had a geriatrician review, and it was the frailer patients who were more likely to have a geriatrician review. The frail patients were increased adverse outcomes, in particular during their admission, increase in confusion and infection, and with follow-up, increase in dependency, falls, readmission, confusion, and risk of death. Now, what was the strengths of this study? It was multi-site, prospective, and we used validated tools. But for me, in the end, the strength of this study was not actually the aim of the study. And that was, I got to know the heart and the soul of patients. I assessed every patient in our site on admission and with their follow-up. And I became the default agony aunt for the patients and their families for the 2 years that I was involved in this study. I was very privileged to be part of that. It was very powerful. And it's something that I realized is very difficult to capture in research. Some of the limitations of this study, the recruitment was lower than expected. COVID hit us. Some of the patients sadly died before we could obtain consent from them or their family to enroll them in the study. Some of the patients were admitted under different teams, for instance, palliative care or geriatric services. So what about the future? Really, Flinders should lead research and system development for the frail older person. We should develop guidelines to help us tailor our diagnostic approaches and our management of the frail older person. They are vulnerable people. They're an increasing group of patients that we will be managing. And with that, I will say thank you. And I think I got through 5 minutes, didn't I? Because no one who knows me thought I would manage to do that. Even Amy was like, Marty, it's 5 minutes. My husband said, you spend hours on 5 minutes. I said, yes, because it's difficult to say everything I want to say in 5 minutes. Thank you.
Yes. Any questions or comments? So I think I missed it, but what was the end point of the study? What were you aiming to demonstrate?
So we wanted to look at what is the prevalence of frailty, really,
right, okay.
because
So
if only, yeah.
So it was sort of an epidemiological
yes,
evaluation. And if I read it correctly, only about a quarter of the older patients saw a geriatrician.
That's correct.
So is that standard practice? Is that gold standard, or is there some other number?
Well, interestingly, that's how I became involved in this study, because I wrote to the Australian and New Zealand Trauma Society to ask what is the recommendations for geriatric or geriatrician review for older patients with trauma, and they didn't have an answer to it, but they knew that they were going to do this study, and hence I was then invited to be part of that. And I agree with you, that is definitely something that's very important. Different systems work differently. I've been fortunate to have worked in different tertiary hospitals with different trauma services. I think we are fortunate here at Flinders that we have a lot of buy-in from the geriatricians, a lot of collaboration with them and the trauma service there, and I know Dieter, our director from the trauma service, work very closely with the geriatricians. So it is something I think is done really well here at Flinders.
So do you have a number here at Flinders?
No, I don't have a number for here.
Yeah, but fractured neck of femur, it's part of the protocol.
It is. Also, Jerry's do it really well.
Yeah. Yeah, so is that not happening with other fractures, other?
We are trying to embed it in our services here at Flinders, but certainly as Marty has alluded to, the engagement from the RAP division has been exceptional. In fact, they've become a surrogate trauma bed card here at Flinders in the absence of a real bed card for a lot of the over 65 patients who are sustained, as Marty mentioned, falls from standing height, but significant injuries.
The short answer is no. Orthogeries are the only service segment that is geriatric on it's formalised.
Yeah, so, but presumably they're seeing all the orthopaedic patients that are over.
We have implemented the peri-operative service.
Right, okay, yeah.
Is available for that as well. But we are trying to get more geriatricians.
And I have to add to that too, the geriatricians has been generous here to admit the majority of older patients with trauma that will not have, that's unlikely to need surgical interventions. And the geriatricians here have really engaged well with the trauma service to learn more about trauma. So I see a bright future here in Flinders.
Okay, maybe we need to discover more about what's happening here than, yeah, for a future project. Andrew, did you want to?
Great research a couple of years ago, so it's great to see it. But presumably frailty is not just age related.
Exactly.
So I'm interested to know how, let's take another view, not age, but let's say we did a frailty assessment. What's the earliest you can do a frailty assessment on a trauma patient? What are the barriers? And then, would that be another approach rather than using age, would actually to come down and do a frailty assessment on somebody and then start to triage the direction?
So at one of the other services that I worked, where I worked on a trauma and older patient risk stratification, we used frailty to be assessed for patients 65 and older, or if they're Aboriginal and Torres Strait Islander patients 45 years and older. There is a lot of diverse views in the literature, whether you start at 65 or 70. I don't mind if it's 65 or 70, but definitely we need to assess for it before we can start implementing plans. And assessing for frailty is, I think, where the future should really go.
Thank you.
Okay, all right.
Okay, San, you're going to talk to us about improving CT turnaround times.
Thank you, Prof. Yes, I'm San Mendes, improvement coach by background. I'm going to talk about the CT improvements that we have done at SALHN. So just a bit of an intro on why this is important. CT scanning is very important because it is a critical service, support service that aids patient flow and quality care in the emergency department, because it can provide fast and accurate diagnostics that is instrumental in sensitive, time-sensitive and life-threatening conditions such as stroke, trauma, pulmonary embolism, abdominal perforation, so things like that. So we wanted to look at how we do in this space, and when we looked at through our patient flow observations, we identified that there are significant delays in CT turnaround time. And when we look at the CT scanning process, usually it's measured in CT turnaround time, and it's further divided into another two sections. We looked into the CT scan to request CT scan request to scan, and then scan to report, and the overall turnaround time. So when we look back at the performance back in 2022, the turnaround time was around 3.95 hours, nearly 4 hours. So that did not really support timely decision making for the emergency department. So that's where we started. And we wanted to look into the people, process, and technology behind the CT scanning process to understand what's actually delaying the turnaround. And we used multiple diagnostic tools to look into this. So we looked into the overall end-to-end process. We did a mapping, and we did a staffing analysis. And we also looked into the CT utilization. So that means the bed utilization time within the CT scan. That's the value adding time in a scan. And we also looked into the internal SAMI process flows. And what we found out was there were excuse me a sec. So we found out that there were extended cleaning time during COVID patient scanning, and there was a capacity and demand mismatch, especially during the early morning when the scans are required extensively. The reporting and the scanning capacity was not in alignment, and towards the end of the day it caught up, but we could not supply the required scans in the morning. And we did a CT utilization analysis, and it was around 62% of a utilization at the time when we started the project. And we did a staffing analysis, and we understood that SAMI did have roster gaps in nursing and PSAs during the night. Although we were a 24-hour service, so there was a significant gap there. And we had minimal redundancies because we were reliant on, the whole hospital was reliant on just 2 CT scanners. And one was, if one goes down, we had significant delays in getting back up and running. So what we did to overcome these, the low-hanging fruit was during the start of the project, we reduced the cleaning time for COVID patients. So there was around a 30-minute downtime. We eliminated that and brought out additional capacity, 6 to 8 patients. We took in additional capacity. We sought to utilize private partners. We utilized radiology SA and got more capacity. We extended the capacity at REPAT, so around 4 hours of more additional capacity was added to the service, and we expedited the CT3 commissioning, and we got that online in October 2023. And we bolstered up the communication as well. We introduced the CT scanning patient transfer standard to improve communication between SAMI and ED department. The SAMI navigator role was introduced, and we collaborated with SAMI to develop inbuild the improvement capacity by inviting them into the improvement program, and they actually graduated from there. So we built that capacity as well. And then we looked at improving the internal processes in collaboration with SAMI. So that had multiple proposals that increased their rostering and address those gaps. So we recruited nursing and PSA staff to mitigate the roster shortfalls and in the night shift. So all in all, what did we contribute to? So we saw between 2022 and 2025, we had a 37% improvement of CT turnaround time. And that was a very significant improvement, provided we started nearly 4 hours of a turnaround. And we have now much better redundancy management and flexibility. If one CT scanner goes down, we have another 2 to manage. And most importantly, we collaborated with SAMI in doing all these improvements, and they have the lean seed in the service as well, because there's around 4 or 5 radiographers and a radiologist going through the improvement program who has the knowledge to improve within. So I believe that it has supported both SALHN and SAMI to a significant instance, and acknowledging Angie Goodrich's efforts in this space as well across the last 3 years. Thank you very much.
Thanks, Sam. Yeah, this project's been a labour of love. We did ask the emergency department what matters to you, and they said improve CT turnaround time. So been able to get it down by about 50%, and it's still going down, which is great. But still, next I think is ultrasound. So any questions? Yes, sorry, Marty.
Well, it's more a comment and a thank you. We're just so incredibly grateful for the work, Angie, that you and San has done, in particular for the older, frail person with trauma. They are the ones with the stealth injuries. They are the ones that were missing out, not getting their CTs, not getting their CT in time. And you listen to us, it has improved immensely. And I don't know how much to thank you for that.
Thank you, Marty.
Thanks. So, San, a lot of the improvement seems to be more staff and more CT scan and whatever. How much can you proportion it? How much improvement was actually due to streamlining processes, getting rid of waste, all that sort of thing? And how much was the increased capacity?
I think, Prof, the first was getting the capacity in place, because we had a significant shortfall to start with. So we addressed that, and we continually influence SAMI to increase the staffing. We are still working with the radiologist and the radiographer requirement. I think there's a statewide shortfall of radiographers and radiologists, so they are addressing that. But we actually indicated the gap, and we addressed the biggest issue in staffing. That was the night shift. So that was, I'll say, around 30 to 40% of that was that, and the 60% was the capacity improvement from the external and our city itself improving.
I can say though, we have increased utilisation of the existing CT scanners. Yes, so we've brought that up from the 60%. That's roughly sitting at around, more towards the 80% now. So we're using the equipment that we have more appropriately, but also we have reduced waste within holding bay and how they flow patients through there, so that the patients were then ready for their scan as soon as the scanner was available, as opposed to delays of patient into the scanner. So there's definitely some system improvements that we've put in place there too.
Yep. So overall, CT utilization has increased around 25%, Prof, from our project.
Thank you, San.
Thank you.
Now, we've got time for a 3-minute break. So we're going to stand, we're going to stretch your legs. We are going to come back in 3 minutes for our next speaker.
Okay. I just want to check if my presentation is on, because I didn't get a confirmation that they got it there.
Let's just have a look.
Oh, yeah.
There it is.
Okay,
yeah,
good.
perfect.
Good.
Great, thanks, Victor.
Because I sent it,
Yeah.
there was no reply saying
you're
I
like,
got it or not. So
is it there?
And as I was coming for this, I was like, what if they don't have it?
Yeah. No, great. Looking forward to it. Okay, we're going to bring you all back together. Sorry, I know that was a very quick break. So if you wouldn't mind having a seat, that would be fantastic. Thank you. It's my absolute pleasure to invite Emma Lesk. Emma is an improvement coach with the Continuous Improvement Unit. And I've got Emma Armstrong, who's a nurse unit manager within the emergency department. And they are going to talk about the TACO Triage Area Coordinator Trial. So thank you, team.
Thanks, Angie. And just want to acknowledge the work of the ED nursing leadership team in this project as well, who couldn't be here today. So, the problem to solve. The emergency department, and it's a big one, big problem, the emergency department demand exceeds capacity with queues of patients waiting to access an acute cubicle for care, in acute cubicles waiting for progression of care, and in acute cubicles waiting to access an inpatient bed. So to understand this problem further, we undertook some direct observations in the ED acute stream to understand what was happening. And this identified two key themes. So the first one was that there was variation and duplication amongst ED nursing roles in responsibility for patient flow. And the second one was the empty cubicle time on the early shift was 7 to 9 hours, which equated to approximately 1 empty cubicle per shift, with an average of 31 minutes empty between patient movements. So using SALHN's 8-step problem-solving process, the ED leadership group mapped the current state of the patient journey from arriving in the emergency department through to departing the emergency department and the nursing roles involved in each step of the process. This identified that there was multiple roles responsible for flow across the patient care journey, and it was not always clear who was responsible for what, with duplication and confusion. So following on from this, we undertook 3 plan, do, study, act cycles, which involved the design and trial of 3 different processes. The 3 trials involved the shift coordinator being responsible for flow into the emergency department and the area coordinators and duty level 3 roles changing between progression of care, clinical support and flow out. So what we found was the shift coordinator facilitating flow in addition to their regular shift coordinator duties, showed minimal improvement with an average empty cubicle time in the north side of 32 minutes and in the south side of 24 minutes. Observations and feedback from staff also highlighted that there was delays, confusion and duplication in communication. So based on this, we designed a 4th process with a dedicated flow in role and no change to the shift coordinator or the area coordinator roles. This was successful in the 1-day trial and showed a 58% reduction in empty cubicle time. Communication was also improved, but there was still some confusion between staff about which patient was next to pull into a cubicle. And what we observed across all of the 4 trials was that patient progression of care and flow out worked well with agreed standards of clinical rounding and the patient transfer standard.
So following the success of that 4th PDSA cycle, we did a 1-week trial in May of a dedicated flow-in role. So this flow-in person, the TACO, they were an additional staff member and their job was directing traffic from the front door into the acute stream cubicles. We also developed a standardised ED order of pull that assisted this person in rapid decision making, identifying the next patient to bring into an acute cubicle. We also trialled a process of automation. So in our ED South, we implemented flick buttons that allowed the nursing staff to press a button to send a text message to the TACO and tell them that a cubicle was clean and ready to receive.
We compared that to a process in our ED North where the North Area Coordinator would send that text message and communicate that information. So we saw improvement in empty cubicle time across both areas during the trial, which was great. We were a bit surprised to find that the area where we trialled our automated process had less improvement than our area where we stuck with an SMS system activated by the area coordinator. There's some factors that might have influenced this. Our geographical layout of our ED means that ED North is smaller and a lot closer to triage than ED South. So, and there's a certain element of parallel processing that could occur where an area coordinator could indicate that a cubicle's becoming free earlier than the button system. So we would need a longer trial to have a look at this automation process and understand that finding. But overall, the feedback from staff was that the TACO role streamlined processes, made their jobs a lot easier, and made the pull-in a lot more efficient. So this trial really demonstrated feasibility, and we're working on an implementation plan to recruit to and educate our staff so that we could implement this role 24/7. Thank you.
Hi, does anyone have any?
Thank you, Neela. So I'm going to continue on my theme. Now, great presentation, and I'm really grateful for this program. Now, my questions for you are a bit difficult, but hopefully we can find solutions. Number one is, how will we integrate older patients having priority in the future, pulling them in from the waiting room? I'm going to say this. I was in tears the other day when I found man in his 80s that was deemed fit to sit and was sitting in the waiting room for 20 hours before he even saw someone. It broke my heart. We have to do something about it. Two, in particular, the frailer older patients, we know they have worse outcomes. The longer they wait to be assessed, have treatment implemented, they become confused, delirium, they have falls. It becomes a nightmare, and in the end, is Amy still here? It makes ramping worse because these patients stay in hospital so much longer, and it starts in triage. Any thoughts on that for the future?
Yeah, I think having been one of the nurses that did the trial, what we found was that this needs to be a really senior decision maker and clinician who can prioritise those factors. I think we have a historical practice in the ED of obviously pulling in order of ATS priority. So if you're a priority 2, you would go in ahead of a priority 3. There's a really large cohort of priority 3s and 4s where we don't have capacity to meet the demand that we're getting, and so we need senior clinicians who have oversight of that area to decide who is the sickest in what looks like an equal group just from a triage category point of view. So I think the ED order of pull doesn't cover all of that decision making, and I think it would be a combination of providing guidelines to staff but also staffing that role with clinicians who have the judgment to make that decision.
Yeah, so once again, this is having to add, well, a whole lot of staff members, one per shift for 3 shifts a day, whatever. That's sort of quite a lot of people. Is there something else that can make it more efficient? And I guess what I'm getting towards is the design. Is there a design of an emergency department in an ideal world that would allow this to happen more easily? Or is it quite independent of design? It just needs people doing all the tasks you're allocating?
I know the layout of our emergency department is really challenging.
Well, I could never find anyone. So
yes, yeah. So for anyone that hasn't
catacombs for me.
for anyone that hasn't been down there, it's sort of little pods connected by long corridors. There's no way to visualise from triage into the acute stream or into resus, and it requires really, really effective communication between those area coordinators and those staff members to have oversight of that. So I think ideally a nice big open flight deck sort of ED is effective in other sites as far as I'm aware, and might be a better layout for us.
Sorry, this is a very random question, but do you know if there's anyone that's looking at the use of AI to help with this kind of issue?
Ooh, not that I'm aware of. No.
So no. Yes.
There's actually an AI scribe study which is saying that a couple of the...
Oh, yeah, there's an AI scribe study, but not one for allocation and... Yeah, but no, the AI scribe study is potentially, hopefully, will be a significant event.
Can I just comment quickly? Sorry. With the order of pool principles, we have met with our SALHN digital team to be able to have a look at how we could use AI to automate so that it could create if it meets the criteria based on the pathways, a criteria-based list to be able to go, okay, so based on this is your, your patients in order of on the list, but then still be able to provide the ability for clinicians to override, going to your point, Marty. Actually, although they meet the criteria, this patient, is at risk of frailty, and I think this is the next one. So, so we are meeting with the SALHN digital health team to have a look at how potentially we could use that to try and reduce the cognitive load and generate, that list. So then if you're the coordinator, you're just then easy to pull the next on the list.
So that's just another quick question. You developed a flowchart there. Did that help?
I think the feedback from the staff was that it really did help, especially from the area coordinators, because previously it was a little bit person dependent as to who was next to come in. So by creating that standard, it was clearer for everybody.
Yeah, it's a relatively small example, but where you've got individuals doing the role different ways, and it's so the time of day of the week, whatever, and it's all different, chaos will reign. So just even simplifying things with a simple flowchart like that, I'm sure would make a lot of difference. So getting rid of unwarranted variation.
Absolutely.
All right, thank you very much. Now I understand we have a change of speaker for the Childhood Respiratory Illness Improvement Project. Petra.
Thank you. Good afternoon. Thank you for letting me present our continuous improvement project here. It's called Bringing Air in and Out of Flinders, and AIR stands for Acute Illnesses in the Respiratory Tract. And I'm not Maddie Stambro, she's our Pediatric Nurse Unit Manager, but she's unfortunately unwell today. So my name is Petra Bos, I'm one of the pediatric consultants involved in this project. So the overarching problem that we wanted to address was that there are inefficiencies in the treatment and discharge pathways for pediatric patients presenting to the emergency department with respiratory illness. And respiratory illness is by far the biggest type of illness that pediatric patients present with to the pediatric unit. These problems lead to difficulties, prolonged presentations, prolonged admissions, and inequity in or inefficiencies in care. So the Women's and Children's Division collaborated with the Medicine, Cardiac and Critical Care Division to undertake this project and use the SALHN 8-step problem-solving methodology in this project. We aim to reduce clinical variation and standardized care, and we didn't quite hit our target by December 2023, but we did get it eventually, which we will show you. So our team spent a long time breaking down the problem and to try to gain a deep understanding of our current state and the inefficiencies in the practices, in our practice and our processes. Through process mapping, we identified several variations, and the largest variation was at the end of the inpatient journey, which involved decisions to discharge and different discharge pathways. We audited our practices against asthma and bronchiolitis procedures and oxygen therapy procedures, and this highlighted delays in nursing and medical officer assessments and also in inconsistencies in oxygen weaning. Direct observations of the pediatric unit ward rounds and of the ED patient journey further exposed barriers in medical officer reviews and poor communication between the team and inconsistencies in oxygen weaning. Poor communication between discharge plan and between the medical team and the bedside nurses. We then brainstormed and multi-voted to prioritize our improvement journey, and that led to 4 key improvement areas. Lack of consistent approach, no documented direct discharge pathway, delays in medical officer review for stretching bronchodilators, time to inpatient review in the emergency department, and ineffective ward rounds. And these 5 key areas then became our focused intervention areas. Between September 2023 and March 2025, we implemented a number of PDSA cycles, and they included the following: criteria-led discharges in the pediatric ward, timers outside the emergency department cubicles, and standardized documentation, nurses to attend the ward round in the pediatric ward, medical scribes in the pediatric ward, alternative discharge pathway documentation, adapting national guidelines for asthma and bronchiolitis, standardized admission pathways, a structured ward round, setting up a daily structure of the ward round in the pediatric ward, and a standardized structure of the morning handover in the pediatric ward. Since the start of our project, we've decreased our median length of stay for all pediatric medical patients by 10%, so that's not just respiratory patients. We have also increased the nurse presence from before and after the trial from 24 to 86% on average. And we also measured the impact of this nurse present trial on other outcomes. And we measured that the average time between decision to discharge and patient actually leaving improved by 65%. And the time between clinical interventions, such as giving out intravenous fluids, ordering paracetamol or a salbutamol trial, improved by 64%. And that's from before the nurses were present on the ward round to when they were present. So our next steps include, we are now developing a more standardized pediatric oxygen administration guideline, which includes standardized weaning processes, and standardized prescription on EMR. We are also writing up role cards for our medical team members. So we reduce the duplication of roles and have clear roles. We're extending the nurse presence during the ward round, not just to the medical team, but also to the surgical teams that work on the pediatric ward. And we've learned from this that the systematic approach, the H-step pathway, really works. It really helps you keeping through the key process. The established relationships between the pediatric emergency department and the pediatric team really helps. It's particularly helpful when there's changes of roles and people are on leave. It really keeps momentum going, and that improvement ideas can come from anywhere, and one person doesn't have to have all the answers. So I'd like to thank our improvement coaches, Tapasway and Sarah, as well as our whole project team and all the staff in the pediatric ward and the pediatric emergency department. Thank you.
Thanks, Petra. I feel like we're going to need to get you all to do testimonials for CIFE because it's lovely to hear all the feedback. One thing that I was really surprised to see and the impact of standardising the ward round. and the impact that that has on patients and their families. So my understanding is by having a standardising, which child you're going to see in which order, provided families the ability to go, okay, my child is going to be 5th on the list. I've got time to quickly go and get some breakfast, or, I might be able to drop off my other child to school first and be back in time to be here for the ward round. So the impact that had on families understanding that they didn't have to wait around all morning to be able to not miss the doctor. And I think that was great as part of this project as well.
Yeah, that was some really good feedback, not from families. It was much clearer for families, because previously families just wouldn't know when a doctor would come. The doctors would just make it up on the spot. We might see bed 1 first, and then we go after bed 23, and then come back to bed 2, and they had no idea. Whereas now we write down in advance, we say, okay, team A is going to see bed 1, and then bed 3, and then bed 5, and the other team might see the other, start somewhere else. And the families could just go and ask the nurses, where are we at? And then the nurses can just say, oh, your child is 5th on the list, and they're only on bed 1, and you're still 5 patients away. So feel free to go and get a coffee, exactly like you're saying. Yep. It's also a lot clearer for nursing staff, so it made it much easier for nurses to actually attend the ward round, because they could then plan their break. My patient is not for another 3 patients away, so I can easily go and get a coffee, have my coffee break now, and then I'll be present there on the ward round. The other thing that really helped was we have a bell system. So the nurses would press, or the doctors would press a yellow nurse presence bell, which is present in all our rooms. They would press the bell to know this is when we're here. And everyone would know then the team is there. And the feedback was that it wasn't just helpful for the nurses to see, oh, the doctors are in this room, but also helpful for the rest of the team. And I find it helpful if I sometimes leave my team for a little bit. I've got no idea when they are when I come back, or if, say, my colleague is doing the rounds, I've got no idea where they are, and I'll just come in the ward and it's like, oh yeah, there's the bell, that's where the team is. So
fantastic.
It's really good communication for everyone.
Yeah. Great use of visual management as well.
Yes.
Any questions for Petra? Thank you. That's great. Great outcomes as well. Thank you. Thank you. Okay, so I'm going to invite Chelsea Swan, Quality Improvement Facilitator, looking at subcutaneous success, improving safe and consistent medication delivery. Thanks, Chelsea.
Thank you, Angie. Hi, everyone. It's a great pleasure to be here today and share this project with you. First of all, I'd like to acknowledge everyone who supported this 2-year project. It has been an extensive collaboration, and we are very proud of what we have been able to achieve when working together. So first of all, just a brief summary of what subcutaneous medication is. So subcutaneous medications are administered into the fatty tissue. They provide steady absorption for a consistent effect over time. It avoids the gastrointestinal tract, which is very advantageous for our palliative care consumers who are unable to swallow, have nausea and vomiting, or other GI absorption issues. It's less invasive than intravenous methods. It promotes patient comfort as we're able to provide breakthrough as required medication as well as background slow release medication, and it's reliable in low perfusion. So when circulation is poor, it is consistent. So in 2022, we discovered that the SALHN medication administration procedure was not consistent with specialist palliative care practice. There was no resource to guide the delivery of continuous subcutaneous infusions, despite that being part of our core business for palliative care consumers. And staff consistently raised concerns about organisational variance in subcutaneous medication administration. And the variability reported was confirmed through an audit of Flinders generalist wards, which showed delays or failures in initiating continuous subcutaneous infusions. No flush of subcutaneous cannulas after medication administration, use of single cannulas for designated medications. So even when medications prescribed were compatible, we were providing single cannulas, which resulted in multiple cannulas being inserted. And on the flip side, omission of cannulas altogether, and staff were administering via subcutaneous needle. So our consumers were experiencing a lot of needle pricks. So overall, the subcutaneous medication practice that was occurring negatively impacted symptom management, increased discomfort, pressure and infection risk, along with the burden of care to our patients, and an update of the procedure was required. We escalated this to our SAP Safety and Quality Committee along with our RAP Medication Safety Committee. They supported us to develop a working group where we initiated the 8 steps to problem solving methodology. At step 4, the root cause analysis, it was clear that the inconsistency in subcutaneous cannula and medication administration was a technical problem rather than an adaptive problem. So we engaged a project management approach. Our consequent steps included a comprehensive literature review to determine best practice, consultation with SALHN clinicians and other relevant committees across SALHN, as well as other South Australian and interstate local health networks. Once we'd gathered all that information, we critically evaluated and discussed and escalated and reported to appropriate and relevant committees at SALHN, which resulted in an updated procedure that reflected best evidence-based practice, and an appendix for continuous subcutaneous infusion was added for both ambulant and non-ambulant pumps. So after we were updated the procedure, it was very important to all members of the working group that we had a thorough change management process and that be attended. So with the help of CNMER and Media and Comms, we planned for that, which was endorsed by SALHN Medication Safety Committee, as well as the Director of Nursing and Midwifery. The resources that were developed to communicate and support staff understanding were communicated to all key stakeholders for dissemination amongst their teams and also uploaded to the intranet. CNMER coordinated a targeted education program which included face-to-face sessions across all areas of SALHN and a virtual session via Teams. During this formal implementation phase, 450 nursing staff members were provided information of the update. Of those that provided feedback, we were informed that it was well delivered, informative and pertinent to their practice. The level of information was enough for them to effectively apply in their workplace and that they believed the knowledge of the topic had improved. I'd like to share a special bit of feedback we received from one nurse who informed we didn't learn a lot about subcutaneous medication and administration at uni, and everyone seemed to have learnt differently. It's good to have some evidence-based updates and clarification. I'm going to have a look at these documents and we'll be putting this into practice at every opportunity. So in conclusion, we're really proud to report that the updated procedure ensures SALHN aligns with current evidence-based literature and best practice. It promotes consistency of practice across all SALHN clinical settings and ultimately and most importantly improves the patient experience through standardisation of administration methods, reducing harm. And we've also provided information on how best to document in the electronic medical record when caring for subcutaneous cannula sites and medication administration. Thank you for listening.
Thank you. Enthusiastically presented. Wonderful. Any questions or comments? Someone stood up, but no. Yeah, so how hard was it to develop the protocol? And I call it protocol deliberately.
Well, developing the protocol was easy. Getting it through the approval processes to publish. Yeah.
So each step wasn't difficult, but the amount of steps to get to where we got, it took 2 years just to have a policy to support subcutaneous use that was accurate within SALHN. So it was a journey.
And it was sort of to get us up to speed with the rest of the palliative care community as well. This is a very well-known and established practice.
I mean, it's an interesting thing, isn't it, that everyone wants to use AI and technology and exciting things, but none of that's going to overcome this sort of thing where there are just huge gaps in what should be really standardised practice. So what were the barriers?
Knowledge, I think. A lot of our teams, like our consult liaison team, provide generalist palliative care information sessions for the wider organisation. When they were delivering those and the people that were attending the sessions would say, oh, but that's not how we were taught, and the policy says this. So it was really difficult for us as a team to educate on best practice when we didn't have a policy to support it.
So you spent 2 years of hard yards, but they were very, very valuable hard yards. Absolutely. Because I think that's sort of something that really should be made visible across the organisation, that there are all sorts of practices. And the bizarre thing is, if you don't have a protocol, you can do anything. Whatever you decide, you can do. But when you want to try and put it in there are, committees to get it through and all sorts of tick-offs and one thing and another. I mean, it's quite remarkably hard to do the right thing. I absolutely agree. But a journey well worth undertaking. Sorry,
That's okay.
Any other observations, Chelsea?
I guess during the process, once we highlighted it to the appropriate leaders in policy procedure guidelines and protocols and corporate nursing, we were respected in we were always referred to as the content experts. But giving the information and complementing that with the literature that's substantially already available to support our cause, once we did need to go through the higher level committees, our respect or value as the content experts maybe wasn't as prevalent as well. So it did complicate the process a little bit.
Fascinating, yeah. Yeah. All right. Yeah, wonderful. Thank you.
Thank you.
Very good. Right. Here we go, Kingsley. It's impact. I'll leave you to explain.
Okay, thank you.
A very good evening to everyone. So here I am to present Impact. Impact is basically my journey through the quality improvement program on our eating disorder group of patients. Eating disorder group of patients are a very special group, and they are quite difficult to handle, and they are time consuming, and they really drain the treating team as such. So when I started caring for them, I found there were a lot of inconsistencies. So it got me talking with the dietetic team, and I got Chloe on board. So we got two of us talking with each other. What next we want to do? Is there something good we can do about it? So that is how our quality improvement journey started. And we said, okay, let's discuss more. Let's see what we can do. And we decided that we can make a change. But how do we do it? Because there weren't many people who wanted to be part of it, we felt. And we said, okay, let's do what we can. We restricted to something like, let's look something simple. Let's look at NG tube feeding time, something we can improve on it and make it very easy. But then once we did the CIP program and we started defining the problem, we realized it is much bigger than what we thought. The average length of stay was around 10.5 days for these patients compared to 6 and below for the GenMed group. And there were a lot of issues with regarding to the multidisciplinary care that can be involved, because these patients are medically unstable, but they need a lot of psychiatry support, dietetic support, and of course, nursing support with the mix of psychiatry and GenMed. Very difficult mix to find too. So yes, it had a lot of problem. And on top of it, 90% of the patients themselves had treatment interfering behaviors, which make it a very difficult group to find. So we compared it against the existing protocol, and we found that we weren't complying with it in many ways. The guidelines which says that we should have MDTs within 24 hours, we do it probably in 6 days. And since the coordination between dietetics and mental health and GenMed, the communication is always going to be an issue, because who communicates what? So that is when we started, okay, good problem to solve. We have identified so much, let's move what next we can do. So we thought we'll gather these information, so we put out feelers into different areas, and we found that a lot of GenMed people wanted to talk about it. We got a buy-in from our department to tell about, or more to say, vent about the frustrations of how it goes through with this. And then we had the mental health team also on board. So we said, okay, let's process map it. And we invited various people for it. And we got 25 different groups from various areas which came in. And that was when I felt like, okay, our momentum is building. We are going to do things better and we are reaching something. And going forward, we did root cause analysis. And surprise, we got 78 root causes. And we were thinking, what are we going to do with such a big number? But we felt that there's so much to do, and we got so many people buying in, we felt we can do more. And that journey energized us to reach out further and did. So first thing is protocol. We got a 28-page protocol. I'm not counting the appendixes to it. So we tried to review it, made it more easier, flowchart based. So we got inputs from various zones to make it better. And we got standardized ED assessments, investigations, and admission criteria to make it better. The dietetics updated their things and made it a simpler flowcharts. And to make the flow of patients better, the earlier thing of mental health and dietetics pulling in referrals so that they can look at caring earlier than being later, put in a referral, then we'll see. So the idea of how we care for the patient also changed. We also are implementing a direct admission pathway which makes things faster. And overall, things are changing. And nursing did a wonderful job. They got all resources together in one folder, which has been a good source for everyone. And the bed managers, we used to have all these patients everywhere. Now we have an allocation protocol in place, so we make it more easier, so streamline of where they're going to be put in. So this is moving on and on. And moving to the next step, what more we can do. We thought like we are restricted to only within our spheres of it. Then we thought, why not the model of care? Why not make things better? And that's when we got more people involved for model of care, higher ups to discuss. And we realized we can't redo things without really impacting it. So we looked at all of these patients having nurse specials, and we are looking at how we can make that as an argument to say how we can improve the care, what we can do. So we are generating a document to push that forward to see to the next level. And we are looking forward to measure and monitor our length of stay as how it's going to get better, the time to mental health and dietetics review for an improvement, and the time to MDT for review. So overall, this journey has been beautiful for me so far, where I realized that everyone in this hospital plays a role in a patient journey, not just what you think you are. And though we all think that we are in silos, working in silos, that generates delay. And when we collaborate, it makes it so much better, and that has brought in more insight. And as usual, the problem is not what we always think it is. It's much better, and together we are making an impact. Thank you.
Thanks, Kingsley. As you can hear, Kingsley's very passionate about this problem, and often at the process mapping, we provide some coaches to help with the map. And when we went to the process mapping, Kingsley was like, no, I've got this. And he got the pen and he did it so beautifully. I think we're going to have to recruit you to the faculty. So has anyone got any questions? What I love is you managed to reduce that protocol from 27 pages to 4 pages. And so I guess the next part is to actually see if, is the protocol being followed? And then, are there some PDSA cycles to be able to look at strengthening that even more? So well done. Well done. Thank you very much, Kingsley.
Thank you. We had beautiful support from our coach there, Hannah. It's been wonderful. And rest of my team from GenMed, Mental Health, Dietetics, Chloe, who's not been here, and all. Thank you.
Yes. Thank you. Okay, moving right along, we've got Stacey Larkham, physiotherapist, which is going to talk. Stacey's going to talk about the global prevalence of chronic pain, pelvic pain in women, a systematic review. Thanks, Stacey.
Thank you. Hello, everyone. Thanks for having me. My name is Stacey, and I'll be presenting on our systematic review exploring the global prevalence of chronic pelvic pain in women. So chronic pelvic pain is common, yet often misunderstood, especially when there's no clear diagnosis. The European Association of Urology defines chronic pelvic pain as pain in pelvic structures, often linked to emotional, sexual and behavioural impacts. It can involve the urinary tract, bowel, pelvic floor, and gynecological systems. Chronic pelvic pain includes both cyclical pain related to menstruation and non-cyclical pain, which is not related to menstruation. Globally, research suggests that up to 1 in 4 women of reproductive age experience chronic pelvic pain. Dysmenorrhea, so pain with menstruation, is the most common form, but chronic pelvic pain can stem from both cyclical and non-cyclical conditions, such as endometriosis or irritable bowel syndrome. Chronic pelvic pain may present as pain during intercourse or affect bladder and bowel function, and often has significant impacts on quality of life. The financial burden is also substantial. In Australia alone, chronic pelvic pain is estimated to cost between $17,000 to $21,000 per woman per year, including healthcare expenses and lost productivity. Our study aims to understand the global prevalence of chronic pelvic pain in women. So the last systematic review was conducted in 2012, looking at dysmenorrhea, dyspareunia, and non-cyclical pelvic pain. Our systematic review defined chronic pelvic pain in women as constant or episodic, cyclical or non-cyclical pain located within the pelvis lasting more than 6 months and unrelated to pregnancy. We searched 5 databases between January 2012 and June 2025, and inclusion criteria focused on otherwise healthy women, 15 years or older, and excluded pregnancy, postpartum periods, and women recruited from healthcare settings, or with a known diagnosis of pain or other health conditions such as cancer. As you can see, this is our PRISMA flowchart. We identified 3,860 records, 198 went to full text review, and 56 met the inclusion criteria. So our review revealed significant inconsistencies across studies reporting on chronic pelvic pain conditions. The number of studies and reported prevalence rates varied widely. Dysmenorrhea had the highest prevalence and was the most frequently studied, and that was followed by non-cyclical pelvic pain and irritable bowel syndrome. Conditions such as vulvodynia, adenomyosis, and interstitial cystitis were reported far less often. Definitions of chronic pelvic pain were inconsistent, and conditions were diagnosed and described differently across studies. Measurement tools, inclusion criteria, age ranges, and study settings varied considerably. The study quality was highly variable. Many studies did not report response rates. They used non-representative samples and relied on unvalidated tools. And there was significant overlap between chronic pelvic pain conditions, with 11 studies reporting on more than one condition. So our review highlights the urgent need for standardised definitions, validated tools, and consistent reporting of chronic pelvic pain research. Despite high variability across studies, the data clearly underscores the global impact of chronic pelvic pain and the importance of improving research quality to better support women experiencing these conditions. This is the first systematic review to examine a wide range of cyclical and non-cyclical chronic pelvic pain conditions, whereas previous reviews have typically focused on 1 to 3 conditions. The high prevalence rates reported across studies suggest that the issue is even more widespread than previously understood. So based on these findings, we recommend that chronic pelvic pain is prioritised in primary health care. So integrating screening into everyday care could enable earlier intervention, better outcomes, and reduced economic burden. Future research should focus on standardisation, using consistent definitions and validated tools to improve comparability and reliability across studies. And hopefully our future research will aim to explore the lived experiences of women with chronic pelvic pain to help shape responsive, inclusive, and women-centred care.
Don't run away yet. That's the quickest escape there. Any questions from anybody?
Good question. I think they're very similar. I think maybe one standardised one for each condition would be ideal. IBS have their own 3 or 4 screening, which is really, really helpful, and that was most consistent across our research, but all the others were very variable. So I think within each of the chronic pelvic pain conditions, having a standardised definition for each of those would be really, really helpful, and then maybe having an agreed upon global definition would be good too, but yeah, one for each condition would be ideal.
So what sparked your interest? Why did you do this review?
I'm doing my master's in health and clinical research, and it wasn't the first thing that I really wanted to look at in terms of prevalence, but it's where I needed to start. And yeah, I just have an interest in pelvic health and pelvic floor in terms of a clinical passion. So
do we see a lot of people in this environment with chronic pelvic pain?
So I'm currently doing a review of postpartum women to see if they document that they do have these conditions. So I'll get back to you on that. But yes, in terms of physio, they do see chronic pain conditions. They're typically triaged a little bit lower due to the chronic nature. But yes.
As soon as you put chronic in front of anything, it seems to go down the pecking order in terms of at least interest and resource. All right, thank you. Thank you very much. Now I need some guidance. Tamina. Oh, sorry, you were hiding there. Yeah, okay. Evaluation of Adherence Counselling Toolkit, supporting health professionals support survivors of stroke to self-manage.
That's it, thank you.
Perfect.
Before I start, can everyone just stand up, please? That's good. Sit down now. Physio talking about physical activity, so I thought I'd better get you to do something. So thank you for staying for the penultimate presentation of the day. My name's Tam Levy. I'm a physio over in rehab and also a researcher at Flinders Uni. And that slide, do I need to move that slide along? There we go. I'm going to talk to you today about evaluating the Adherence Counselling Toolkit. I've spoken at the last 2 research weeks on the co-design and development of my toolkit, so I'm not going to talk about that today. But if you would like to read up on it, the co-design paper was published this year in Disability and Rehab. And if you want to actually look at the toolkit, you can just go onto that QR code. It will take you straight to the toolkit. And actually now, if you Google Adherence Counselling Toolkit, it's the very first thing that comes up, which I think is pretty cool. So we created the toolkit, and then we were thinking, well, how are we going to evaluate it? So we applied for one, which was great, a Flinders Foundation grant, to look at an evaluation study. So we chose to do a type 1 hybrid implementation effectiveness study. So hybrid studies are really good at accelerating that link from research into practice. And hybrid type 1 studies look at preliminary efficacy of an intervention. That's the main thing, but they're also collecting data about implementation, which is going to help guide future research and future practice. So our aims were to explore the preliminary efficacy of the toolkit on adherence to activity in stroke survivors, as well as the efficacy of the toolkit on the confidence of the stroke survivor, but also the confidence of the health professional who was, sitting with the stroke survivor, developing programs that were individualised for that stroke survivor. And then, as I said, secondarily, we wanted to explore implementation factors. What were some of the contextual factors that influenced how effective it was? Was it feasible? Was it acceptable? All those sorts of things. So we did a mixed method study. We had 30 dyads. Actually, we had 31, which was super annoying because I don't like numbers like that. I really wanted 30. 30 dyads across all of the RAP stroke services. So that included inpatient wards, day rehab, our home rehab, and even our virtual rehab ward. A dyad meant a health professional and a stroke survivor working together. And we aim to recruit 30 stroke survivors and at least 10 health professionals. So that meant that a health professional could include three participants, and we actually ended up with 18 health professionals, which was a pretty good number. The outcome measures we looked at: adherence, everyone filled in a 4-week diary. We looked at validated self-efficacy scales for the stroke survivor and the health professional. We did a feasibility survey, and then we really wanted to find out, what was it like? What was the experience of using this toolkit? So we did some qualitative research in terms of interviews and focus groups. So basically how it ran was the health professional would do a consent for themselves, then they would identify a stroke survivor to work through the toolkit with, and then they would go for it. The toolkit, if you do get a chance to look at it, has multiple different resources and options that you can use with someone who is at the early stage of change, so they're not really ready to be active, right through to someone that's super duper motivated. We've kind of covered all bases. So we sort of left it up to the health professional to work with that specific stroke survivor and choose their own adventure, so to speak. We checked in every week with how they were going, and then after 4 weeks we did our outcome measures again. So some of the results we had, so this was our feasibility survey. So over 90% felt that it was helpful for promoting and improving physical activity. And interestingly, nearly 85% thought that the toolkit, which was originally designed for people with stroke, could be used with other conditions. And so we were really mindful of that when we were developing the toolkit. A lot of the resources that we have in it are very generic, based around behaviour change theory. So it is definitely something that you could use with those chronic, people with other chronic conditions who, as you've just mentioned, often miss out on other aspects of health. Was that the 1 minute bell? Okay, sorry. Adherence was pretty good. So 75% adherence to their program, which meant that if we were asking them to exercise every day over 4 weeks, that's 28 days, they were doing 21 days. Over 4 weeks, definitely meeting physical activity recommendations, and some really nice qualitative quotes around giving the health professional confidence, things around goal setting, motivational interviewing skills, all those sorts of things. So it was people were very engaged with it. Self-efficacy of the stroke survivor significantly improved, and self-efficacy of the health professional also improved. It wasn't significant, and I suspect that's because it was pretty high at baseline. So in summary, really positive results. This is currently under review in disability and rehab. After we'd analysed this, it was about May this year, and I realised I had quite a lot of money left that I needed to spend. So we were very lucky. We got a professional videographer, we got a professional graphic designer, we created some great videos that are now on the toolkit, some really nice resources. So we made some real changes to the toolkit based on the analysis. And then amazingly, a year ago, I was successful in winning a SALHN grant to do an RCT, which is currently underway. We've recruited 15 people, so that's not too bad. And then we need to start thinking about what next. So we've done a pilot study, we're doing an RCT. So what do we do next? Do we need to do a bigger implementation study? The final little thing was I spoke to the Stroke Foundation 2 weeks ago and showed them the toolkit, and they loved it. And so this is pretty exciting. They are going to put it on Inform Me, which is their where all their great resources are. So I think that deserves confetti.
Yes, absolutely.
And I'd like to really thank SALHN Research again for supporting this research with 2 very generous grants. So thank you.
Well done. Thank you. What a fantastic improvement to that compliance rate. 21 days. I know how hard it is, amazing. Any questions? No? Wow, thank you. That was great. Yes. Dyad. Where did that come from?
I actually can't answer that question, but it's just the pairing of 2 people together.
Do you have a phobia about prime numbers?
No, I just thought 30 was lovely and 31 was just shocking. So anyway, I was a bit annoyed by that last participant.
Fantastic. Thank you. Okay, lucky last, and look like a bit of a change in title since the last time we met. So Dr. Lang Duo Chen, or Chen as we otherwise know her, Nurse Unit Manager for the Tobruk Rehab Ward, and Chen is going to talk about embedding partnership in eye support program with carers to improve. So over to you. Thanks, Chen.
Thank you, everyone, for staying the last one. So I'll get onto it straight away. So people living with dementia are overrepresented in hospital, and their length of stay in hospital is usually longer than those without dementia. These hospital admissions actually are preventable with timely and appropriate support to the carers. But as we know that carers often receive less dementia-specific education than health professionals. To fill this gap, the World Health Organization developed a psychoeducation program called Eye Support for Dementia Care program, which is a global program, and it has since been adapted to the Australian context. So here in Australia, we developed a facilitator-enabled virtual program called a Partnership in Eye Support program, and we also trialed in Australian hospitals. The trial result demonstrated improvements in carers' mental health-related quality of life and self-efficacy, and also compared to the usual care group, the control group participants had their dementia patient had significantly less presentation to ED and hospital admission as well. So today I'm reporting on the findings of the knowledge translation phase of this large project. The overarching aim of the study was to support carers of people with dementia or cognitive impairment and improve the quality of life for both the carer and their loved ones. So the Eye Support program has 6 modules covering information from basics about dementia, how to self-care as a carer, how to manage the behavior and service support available for them, also how to relinquish their role when their loved one goes to the residential care facility. This is a snapshot of the knowledge translation phase, which is a 6-month implementation phase. We engaged with 57 carers and 52 clinicians across geriatric services here at SALHN. Carers received support from the Eye Support facilitator, and clinicians received education based on the Eye Support manual. Data were collected through carers' pre- and post-intervention survey interviews and clinicians' focus groups. Each carer received the Eye Support manual, either electronic or the hard copy. They generally opted to receive monthly phone call contact, but if they require more frequent than that, that was provided. Based on their needs, we provide information on available services and support. We frequently refer them to Dementia Australia and also the peer support group in the community. The carers also welcome the WhatsApp group as a virtual peer support. To assist with the sustainability of eye support in our service, we actually developed a narrated eye support training video for clinicians' education, which is available on iLearn. We also developed an eye support toolkit in consultation with clinicians. The toolkit includes information sheets about eye support and how to access the manual online, and young onset dementia, strategies to support ADLs, and transitioning into the residential care facility. The carers found the Eye Support manual beneficial and they desired to have received these at the time of diagnosis. They perceived that the iSupport manual supported their long-term planning, enhanced their ability in self-care, and managing changed behaviors. Information on services and support was viewed as essential in healthcare delivery. iSupport program also improved the clinicians' confidence in educating carers about dementia and how to self-care and to manage their changed behaviors. The clinicians also identified the timing of providing this iSupport manual and information to the carers as areas for consideration if fully embedding this program in standard care. We are in the process of engaging with geriatricians and service managers to develop workflows of including the program in standard care. Thank you.
Yes, thank you. Does anyone have any? Yeah, right at the back there.
Yes, so in the trial, in a clinical trial, which is a phase 2 of the study, we also analyzed their ED presentation and also hospital admission. So compared to the usual care group, the intervention group participants, their loved ones, of course, is the carer who are the participants. The people with dementia had significantly less ED presentation and hospital admission.
Right, very good. Well,
Yes.
thank you.
Thank you.
So, Andrew, did you want to make any comments or? It's the easiest way I can get out of it.
Well, first of all, Rob, I just wanted to thank you and Angie for just being, such excellent, attentive chairs, because it's, so thank you. And really just to reflect on, it's an extraordinary quality of stuff that we've heard today. I think we should all be very proud of each other, the work that we're doing here. I think, Rob, you've been doing a lot of this work has been improvement work. You've obviously been involved for a long time. Some of us are newcomers to it, but it really seems that we go from strength to strength each year. And, it's fantastic work, and I look forward to hearing more of it next year. So thanks very much, everybody, for all the efforts that you made, but be proud of what you've done.
Thanks, Andrew. I think there were some really, really good themes that came to light. And I think that the effort to try and break down complexity and simplify things and make it visible so that we can provide a much better quality service. I mean, that was a really valuable theme throughout quite a number of the presentations. I think the difficulties with getting protocols signed off, that was part of what was being spoken about there. I mean, that's something that we really need to address as an organisation, because if it's too hard because there are barriers that we impose to make things better, I mean, really, what are we doing? And the fallback position is, well, everyone just does their own thing, and we know that that is extraordinarily chaotic and really makes a mess of things. Chelsea, you've been stimulated to say something else. So, you're right. When you say we can't get the overall governance,
people do find that as a barrier. The process, they try to go through the process, do the right thing.
Yeah.
But because of the layers and the problems they encounter, they just normally path of least resistance and create a local process.
Sort of secret unit business.
A little bit.
Yes.
And yeah, it is. I find that it's a bit sad because we can't all support each other in our learnings and what works well.
Yeah. So, Andrew, I mean, it's a little bit of a challenge in a way, but there are many things that come up at these sorts of events. And I just wonder how it is that we carry them forward through the year and make them visible throughout the organisation.
Well, it's a great challenge. You know, it is a challenge. I guess the first one maybe I'll pick up, which is signing off of protocols. So, I mean, many of you won't have been there, but we launched our strategy. And one of the big pieces of the strategy is around infrastructure, and it's actually the infrastructure of knowing how things work and making it obvious how they work so that everybody can see that we understand the processes and we don't come to closed doors all the time, which is what happened. That's how you take 2 years, is you get to a closed door and then nobody knows how to open it. So I think we're going to work, that's really part of the strategy. I'm really pushing that quite hard. I think that makes it much easier. It should be very obvious what we have to do. The approval, you know, people complain about approval times in research sometimes, but actually when you know what to do, the approval times are great. When you don't know what to do, the approval times are slow because you're struggling to find it. So I think we have to work part of that. I guess how do we get some of these insights to become obvious across the organisation through the year? It's a much tougher problem because we have so many competitive operational pieces that are going on, and anybody who's spent more than a minute with me will know that all I think is we've got too much faster and not enough smarter insights, and so we're trying to press on that. That's part of why we have Research Week. It'll be part of the insights, will be part of the report back from Research Week, where we're here to try to support people to make them visual. We meet with the divisions now twice a year. We have lots of meetings. We'd like to have, and in those we'd like to hear people present some stuff so that it becomes obvious to the people in the meeting there as well, because I'm not sure that all the divisional directors know what's going on in their departments. So I don't really have much, simple answer to it because it's a complicated problem, Rob, but we're trying to address some elements of it.
Yeah, I mean, more and more, a lot of the things we're hearing here is how do we continue to do the routine things well? And I think, there's too much time spent talking about innovation and change. Not that they're not important, they are, but you need a solid base to do it. And unless you've got the base, and that's doing the routine well, you'll just produce more chaos. Yeah. We'll leave it there.
Okay, good, thanks.
All right, thanks very much, everybody.
Very good. Excellent.
Thanks for having me. Oh, you did so well. Thank you. Thank you.
So, Corona night tonight, 4 decades of Sordo. For reminding.